call the meeting to order. Before we get to the formal business of the meeting, I want to welcome James Perino, who is the newest member of our board. James has a distinguished career at the department, now re-enters this business as a member of the Board of Correction. Welcome, James. Thank you.
Thank you.
So first, we'll approve the minutes of the January 2017 meeting. Minutes have been distributed already. Is there a motion to approve?
So moved.
Is there a second?
Second.
Does anyone have a question or comment or any revisions proposed for the minutes? Hearing none. All in favor?
Aye.
Opposed? Thank you. Vote carries. Next item on the agenda is we'll hear now from Dr. Patsy Yang of Health and Hospitals. She'll present the H&H's transition to direct health care provider for all of the department's facilities. Dr. Yang?
Good morning. I think I don't have a clicker. That's the cover slide. Good morning. So we wanted to update the board on post-transition, what's been going on in the last year and a half at Correctional Health Services since we came over to Health and Hospitals. We've made improvements in four key areas: workforce and infrastructure, in terms of safety and our relationship with DOC, and in terms of improvements in leveraging Health and Hospitals programs and services. So on October 1st, we became the direct health provider in all the jails. That was marking the expiration of the contract with Damien Family Health Centers, which was doing services in the Bronx. And that followed the Corizon expiration in January of 2016. We systematically vetted all Corizon and Damien staff. We hired about 85% and 75% respectively of those staff, some on probation, almost 30% of whom didn't successfully complete their probationary period. At the same time, we've been creating a single unified management team. We've been able to increase our recruitment of highly qualified, committed health professionals from great places in the city and outside the city. We've been able to fill our positions with a lot of professional staff. We've had about 230 hires since January. We've been able to strengthen support of our frontline clinicians, both with increasing and changing our supervision. So there's clinical supervision now in every PACE, CAPS, and MO unit, and created a clinical education office specifically dedicated to supporting and training our frontline clinicians as we change practice. Thanks. Infrastructure improvements. We've created new departments within the Division of Correctional Health Services. One is that we created an operations department headed by Beth Ward that's really focusing on accountability and safety. Policy and planning headed by Patrick Alberts really focuses on collecting, coordinating data analysis, data reporting, as well as investigations of incidents. We've integrated mental health and discharge planning staffs into a unified mental health service that reflects our increasing population and our focus on delivering good care, identification, screening, treating, and discharge planning. Our clinical quality management office is singularly focused on quality. That's tied in also to the health and hospital structure for quality of care. And we created an addiction medicine office that's actually coordinating and centralizing all the different SUD programs and services that we have. Largely because of Health and Hospitals relationship, we generate a lot of savings by capitalizing on their supply chain, their procurement, and their inventory management that covers everything from med-surg supplies to computers and beds. We've incorporated new software applications both from Health and Hospitals or ones that we've developed on our own for employee credentialing, staff scheduling, purchasing, and timekeeping. We've also reorganized specialty care to more efficiently and effectively meet patient needs. We've actually reduced our reliance on private vendors by 75%. Next. Yeah. Thank you. We're working on jail safety with Health and Hospitals, incorporating into their workplace violence prevention program. We have a dedicated safety officer within the operations department. We've surveyed every clinical space and worked with DOC to actually implement safety enhancements in all 12 jails. With the City Office of Labor Relations, created a workplace safety committee that involves Department of Correction, COBA, and the 4 health unions, 1199, DC 37, NYC, and Doctors Council. We are collaborating on developing our relationship with DOC. We have daily, weekly meetings at executive and facility levels to deal with challenges that are coming up for the day and more strategic problem solving. We actually established a joint assessment and review process for major incidents. When we've had significant incidents, both agencies review and come up with their own findings, share them, and mutually agree on systems changes or policy changes that can actually help reduce the likelihood of recurrence. We've increased joint trainings as everything from de-escalation to recognizing and reporting abuse. And we are supporting DOC's targeted system-wide efforts to increase production. Actually, with being in health and hospitals, we actually realized that we have about 47% of our patients are common between the health and hospital system and correctional health services. So knowing that, we've been able to leverage a lot of our relationship with the larger system. On patient scheduling, for example, we took over the Bellevue, from Bellevue, their specialty clinic scheduling, and in doing that, we've cut by half the wait time for urgent visits and down by 9/10 actually for routine non-urgent visits. We actually created the first telehealth program in the health and hospital system, and they started at Bellevue. There's like 4 or 5 services there who are now doing telehealth with us, and that's among and within the jails as well. We are sharing our records with Bellevue and Elmhurst and Bellevue are sharing theirs with ours electronically until we get on the same system, so we have more on-time and current information when we're sending people for inpatient or specialty. We streamlined emergency transport. This has taken a couple of years to actually get off the ground, but working with Bellevue, Elmhurst, EMS, Sydney EMS, and Department of Correction, we pulled 2 rigs off of the 911 system, which lets you get around the requirement that you go to the closest available facility, so that stable male patients can now go directly to Bellevue rather than having to stop at Elmhurst, which was a really lengthy and disruptive process. As a result of that, Elmhurst has seen a decanting in their ED by about half, and Bellevue has seen the direct transport, but it's a manageable one given the size of the Bellevue ED. I think that's been a positive thing for EMS in terms of rigs available in the community, and for DOC escorts to be, the entire thing for our patients in DOC is just it's not a 19-hour journey. Thanks. The other thing that we've done in terms of health and hospitals programs and services for our patients after incarceration or after release, we created an assistance center that's across the street from the bridge to Rikers. And people can stop there on release and get insurance, expedited appointments within the health and hospitals FQHC system, Medicaid, managed care, home health services, case coordination. Metro Plus is also outposted on Rikers Island, and they've been signing up people and our patients and families to ensure Medicaid coverage on release. Gotham Health, which is the Health and Hospitals FQHC network, their ambulatory network, is offering expedited appointments for our patients prior to release for both primary care and mental health services. And the post-acute system, we've been working with health and hospitals, and in particular Kohler, and have actually managed to transfer and move some of our patients who need palliative care to a much more clinically appropriate space. We've also been changing the way we have been approaching service delivery. Our enhanced pre-arraignment screening unit started 24/7 in Manhattan on November 1st. Our PACE program, our program for accelerated clinical effectiveness, we are tripling that number of PACE units. We actually opened one in September for people who are coming back from OMH hospitals, and we've got 2 online for this fiscal year. We're working with DOC on patient cohorting for specific populations of vulnerable patients, and that's to improve both operational efficacy and therapeutic efficacy. And we're on Rikers Island distributing naloxone. We are doing about 1,000 kits and training a year at the visitor center, which has proven to be very, very our visitors are able and live in an environment and with populations where this has come in pretty handy. Okay, good. We're expanding hepatitis C treatment. We negotiated an unprecedented discount from Merck, and we're able to triple just since last year the number of people who we can initiate treatment. We're partnering also, again, with Gotham so that for those few individuals who need community completion, we can be assured of a warm handoff and an agreement where we know where patients are going and that they're actually finishing and going to cure. Again, telehealth at Bellevue, we've got ID, gastroenterology, urology, and rheumatology set up. We're also using telehealth with Kohler for assessing appropriateness, clinical appropriateness for long-term care placement. And we're moving to install throughout all the jails, other health and hospital systems, and the New York State Forensic Hospitals. We have some money for satellite clinics. We've opened 3 of them already, 5 of them in 3 jails. And we're going to tie up the rest of them and connect them to our areas where we're going to be cohorting patients, so to bring care closer. I think that was it. Was that it? That's the countdown.
Any questions, comments from the board? Yes.
Thank you very much, Patsy. So I wasn't sure how much could be accomplished in this period of time. It's very impressive, particularly some of the things that I don't think other jails around the country are doing in terms of access to treatment. I do have a fundamental question, a couple of them. One is, and I'll ask them and you can answer them all together. Do you know who is requesting? We're going to talk about data in a few minutes, but as the Health and Hospitals Corporation, Correctional Health Services, do you know who is requesting sick call on a given basis? That's one question. 2, I'm glad to hear that you're having a pilot around access to Bellevue, although I believe, as Dr. Sacchi and I both recall, this was routine. Clinicians can assess whether someone needs to be at Elmhurst as soon as possible, or whether it could take an hour or an hour and a half or 2 to get to Bellevue, and it's disturbing that's not a fact. That's not sort of implicit in your management. But hopefully, this pilot will get you there. I guess. And then the other thing is, it's not going to be on either of these things. That the use of the CAPS units and the PACE units. Can you just discuss sort of where you're at relative to where you'd like to be? The numbers seem pretty low to me still.
Okay. The sick call, I think I'm going to wait until we can talk about the access report in general. The Bellevue pilot, the bypass, there were legal issues about getting out of the 911 system, which is why we ended up doing what we did, which was actually pull the 2 rigs out and dedicate them to Rikers so that we had an EMT and a para on each of the 2 rigs. I think those are probably going to be there. We're going to call off the pilot status pretty soon. Whether we can expand it or not will depend a lot on demand. But I think it's working out for everybody, so I think we can continue that.
Just curious about how many people have signed up for the Health First or Metro Plus?
Yes.
So the number's large.
The numbers, actually, it was, I think we have 160 people who were enrolled, period, but 145 were the Metro Plus. And Metro Plus will enroll in other plans if they ask, like Health First.
There are significant numbers showing up at the clinics. Because they're in more places.
Right. So we continue to meet with Gotham to do better tracking in terms of who's showing up and why. But we are certainly making appointments. People can still vote with their feet. We make every effort to try and make it expedited, same day, in fact, when you ask. And we're continuing to work with them. We're talking to the larger health and hospital system also about, we're calling it stickiness, but for Metro Plus or Gotham, how long people stay connected to that care in the community.
One more question. What's the discount?
Yeah. On pain of
Good
death.
job.
Thanks.
Any other questions or comments? So now I think we can move to the present of the Health and Mental Services Access Report for the period from July 2016 to January 2017.
My name is Patrick Alberts. I'm the Senior Director of Policy and Planning. My group puts together the Access Report. I'm just going to kind of go through some of the highlights. It's a very dense set of numbers to take a look at. And it's also self-explanatory in a way. Just go through that and then give some thoughts on what we can do to move forward with the plan itself. So the Health Access Report was created at the board's request as a tool to measure health access across several categories: sick call, health visits, mental health, and on and off island specialty encounters. While these measurements are similar across the board, service types represent complex and different workflows. So some of the services are delivered in the same physical spaces, but the results you see in the report are much different. For instance, if you take a look at the health encounter scene, it's near the 80% mark, while the mental health encounters is hovering around 70%. A significant reason for this is a requirement that upstream mental health encounters occur within 72 hours of referral. So that's an indicator, a requirement that medical does not have to deal with. Likewise, this might be a contributing factor to the reason why there's a high CHS mental health canceled rate for the mental health encounters. I think right now on the medical side, cancellations fell at the beginning of the report from 1,200 cancellations to around 300 today, showing kind of a sustained workflow improvement within the clinics to prevent cancellations and unneeded work. Our service focuses on patient encounters as the measurement unit, but over time we've also added distinct patient scene to give a view into access at an individual patient level. I think this is just kind of a distinction between the way that mental health and health thinks about patient care and the way that movement actually happens within the jails. So the way that would work is that if a person shows up at the clinic and they have 2 encounters scheduled for follow-up, if they make one, they don't make the other one, that's a 50% scene rate. On the distinct patient side, since they showed up for that day, it would be a 100% scene rate. So it just gives you kind of another view of what's happening in terms of people getting to the clinic and then what might be happening while they're inside the clinic. Likewise, the report measures DOC production. If a patient doesn't show up to a scheduled follow-up appointment, the clinician encodes that encounter is not produced, so it happens right at the time that the patient shows up. Does not show up, I'm sorry. However, there might be other reasons that our patients aren't seen. Refused verified actually means that the DOC brought the patient to the clinic and kind of followed the accepted workflow that we've kind of long held, is that the patient refuses to health and mental health when they have a follow-up appointment. So in that case, and refused verified, the patients come to the clinic and they've actually refused to us. Same thing with left without seeing. The patient has been produced to the clinic, but they left before we could see them. Mental health has shown essentially kind of a 24% not produced rate, so that's kind of one of those sticky issues that we have to work on together. On and off island specialty encounters, though, have shown improvement. Really a success for the department. I think it's been around a 10% improvement since the beginning of the measurement period. So it's shown, for some of the hardest encounters for people to actually get to, on island occurs on the island, but it requires transportation within the facility. Off island, as you know, requires transportation off. So sustained improvement in that area is quite an achievement. So just to take some the takeaways from the report, data collection from our perspective is key. This report is made possible because CHS has an EHR. All important clinical workflows are regularly documented there by our clinicians, and we have a team dedicated to making that data available and transparent in the report that you see. All major service changes and workflow decisions should begin, from our view, with a discussion of what we know about the current state. The fact that CHS has a robust and transparent data collection program makes that possible for us to have that conversation. Another benefit of this report is that it gives us the ability to measure consistency within the process. So while this report isn't a year old yet, we're starting to acknowledge that some of these processes are stable, indicating that regular workflows are discernible and repeated. So on-island workflow looks to be stable, at least with the numbers that we're seeing in terms of the scene rate, production rates. The health encounters metric is showing beginnings of sustained improvement. So again, I think this is something we wouldn't be able to show unless we're showing this data regularly and in this forum. And in those instances, it's really up to our joint efforts to come up and to make these processes more capable. So I think with that, we've had a chance to look at this data. I think from our perspective and from the perspective of the department, there's things that we can do to improve the report itself. I think to reflect on-island workflows a little bit better, to give you an idea of what's going on. I'll turn it over to my colleague here to talk about a plan for doing that.
So I think over time, as we've had these discussions every meeting about data collection and production, I think one of the things that has become very clear to us is that there is probably a better way we can present this data so that it can be better understood and we can have a very comprehensive picture of what it means and what it doesn't mean. I think we're both in agreement that we're going to collaborate to look at all of the things that impact access to care. Production's a part of that, but there's also several other things to look at. Cancellations, refusals, people having court, or other things that are happening simultaneously. So we're really committed to kind of working together to look at all of the different variables and what are other things that we can do that can impact it. And we have some ideas that we've been talking about that may impact that. We have decided that jointly we're going to develop a strategic plan that we would like to give progress to the board about over the next upcoming meetings about where we are in working as a team, because we recognize is through our discussions, we're jointly motivated to make sure people, not only are they getting to the clinic, but that they're actually getting the services that they need, but how can we make sure that they're getting those services that they so critically need on a very regular basis. And so we think together, we've already done great work, we like the direction that things are going, but we'd just like to do more work together as a team.
Very good, thank you. Any questions or comments? Yeah.
Hi, thanks a lot for that report. Just have a couple of questions having to deal with the mental health encounters. And I know, and I know you said it, and it just may bear repeating, but looking at these numbers, about 2/3 of the inmates are being seen for the encounters. And you mentioned that the reason for not being seen, I believe I heard, was refusal to be seen, where they walk away before.
So for mental health encounters in particular, there's a couple of factors. So with patients not being produced at times, CHS cancels. So the fact that we cancel appointments within our own service, so we will essentially book too many appointments for a particular day, and then we'll have to cancel them. That kind of shows that we have the way that the report is set up. It shows you what's scheduled for a particular day, essentially. And so if we miss any of those scheduled appointments, for example, if we cancel them, it doesn't reflect necessarily the fact that we do see them later on, but it'll show that, but it also shows the fact that we canceled earlier. So cancellation is one, the non-production is one.
Court.
Yeah.
If they're in court, if they've been transferred out of the facility, may be a reason. And refuse verified, like Patrick had said before, somebody gets to a clinician, they talk to the person, they're educated, and they decide not to come.
Okay. Is that all documented? I'm coming at it from a liability point of view, because if the individual isn't seen and then goes and does something to harm themselves, is that documented in their electronic record that they actually showed up or the appointment was canceled? So we have some basic recoveries to say the person was either canceled by us or refused to be seen.
Right. So all of these processes, like I said before, are recorded. So if someone doesn't show up to a mental health encounter for whatever reasons, the fact that we canceled it, we are rescheduled. If someone isn't produced, we're also rescheduling. We're also talking in the facilities to DOC about patients that absolutely need to come to certain encounters for a reason. So there's a lot of work that happens at the ground level. I think you're looking at the really high level view of the entire service doesn't reflect a lot of work that's happening in the facilities. But just so you know, the way the cancellations work in correctional health is that we schedule the appointment to make sure the patient's seen.
And this is one of the reasons why the clinic huddles are so important. So we are able to have that joint discussion at the time about who must be seen, who's missed an appointment and needs to get back into the clinic. How are we prioritizing individuals? So that everyday discussion that we do together jointly really helps us be more effective in getting people to their clinic.
Yeah, my only concern was that just not having anybody fall through the cracks, so that you're at least accountable, held accountable for people not showing up or refusing treatment.
Dr. Cohen?
Yeah, the way I read the mental health encounter data is that of the, that there were large numbers of people who were never produced. I mean, the vast majority of reasons that people are not seen is because they are not brought to the clinic. In NYC, for example, there were 5,226 people seen, but there were 1,498 not produced. This was not about not being in court. This is not about refusal. This is about the Department of Correction not bringing that number of people here. So to your question, yes, it is documented. I've reviewed the charts. There still is a substantial problem in terms of production, and I assume that you're working on it, which is why you're here collectively presenting. But the data to date does not suggest that this thing has been at all resolved. And actually, it came up because we reviewed deaths, where in mental, suicides, where people were not, had multiple scheduled appointments for mental health because of their severe depression and changes in medication, and did not get to the clinic. Hopefully, this is improving, but the numbers are pretty slow in terms of the way the graphs look. They're not. The slope of the delta is low.
So Dr. Cohen, exactly like you mentioned, I think that's one of the reasons why we're jointly talking about how we're going to be reporting this data. So the numbers you quoted from AMKC, the 5,228 that were seen, the 1,498 that were not produced. But of those numbers, there were only 6,719 available to be seen, and we produced 78% of those individuals. The other reasons that they weren't brought to the clinic were, just like Patrick Alberts had talked about, was the fact that we have the refuse verified, the cancellations, the courts, and the transfers, which is one of the reasons why we want to talk together as a team about what's a better way that we can make sure that we're representing this data to the public and also to the board so that we have a more comprehensive understanding of what the numbers mean. And we're talking using the same language to talk about the same things.
Another question. I'm not sure if you answered it. I didn't hear it. To health and hospitals, do you know the names of everyone who has signed up for sick leave? So that if someone doesn't show up, you know that they were not produced?
So that process is managed by the
Excuse me?
department. The process is managed by the department.
So the answer is that you do not know who has requested to be seen. Can you explain the logic of that? I find that extremely disturbing, that the medical provider does not know who is seeking to see them, and that the access to medical care is determined by the Department of Correction, not by the clinicians.
So Dr. Cohen, I mean, is that okay? Can I answer? So every single day there are sick call sheets that are presented to the clinic. They're discussed and huddled in front of the medical providers in the moment. And there's a decision made when they're looking at the full picture of what the clinic needs to do that day as far as urgent medical follow-ups, urgent crisis, about how will they prioritize who's coming down. And those individuals that aren't afforded or aren't seen or is decided they're going to be seen that day, they will be rescheduled, and the medical providers will do follow-up.
But you're not. But you know who's requesting care. Medical does not know. Who's
We give them the list. They get it every day.
I didn't hear that. I didn't hear that from Patrick.
So that's how we know that people are going to show up. DOC gives us.
You get a list of everybody who signed up for sick call.
So we get a sick call list essentially, and that is the list for the day of people that.
Is that a list prepared by corrections based upon forms, or is that do you get direct access to who is requested sick call?
Individuals actually are given a sheet, they sign their names, and that's provided to the providers.
Do you have any reason to believe, Homer, that you're not getting the whole list?
Yeah, there are. I think that this process of paper-based lists coming to us from, imagine the hundreds and hundreds of housing areas, 12 different facilities. So the paper-based program process we have, if you talk to the clinic staff, the clinic health staff, they don't get every day a list from every housing area. I think there are some facilities where sick call access is a problem, where they are at C71, some other areas. Other parts, it's not an issue, where the process works very well. And the sick call lists come in, but they don't come in all the time, and they don't come in for every housing area. I think that the benefit of the huddles and the joint work is every jail knows the housing areas that either for high security classification issues or MOs, places like that, where they struggle with access, where we may send staff out. But I think that it's fair to say that the system we have, because it's paper-based, because it would rely, right, as described, we rely on thousands of pieces of paper with zillions of names written, is not reliable. And so we work to, as a stopgap, to harm reduce the lack of transparent, real-time information that Dr. Cohen was asking about.
And this is another thing we're going to be discussing when we talk about the plan that we're going to develop, about things we need to look at to make sure we're addressing in a more comprehensive way with our plan.
One thing you might consider is just automating that particular process you just described, the paper-based process. I mean, I don't know how much trouble it is, how difficult it is, but obviously it would facilitate more current information, more reliable information.
So we actually looked at this when I was going to call him Jeff Perino, but when he was back in RDC, we really looked at this. You can drop kiosks into housing areas where people can push a button and they can say, and then that information is real time, reportable, and knowable. I think that the jails, it's a tremendous struggle with IT complications of implementing anything like a tablet computer or something much simpler, let alone a hardwired system like this. And so some of the patchwork approach here reflects the staff, having a real dedication to addressing these issues in the face of some physical plant struggles that are quite real.
Can you also, and you and I have over the years had a conversation about this from time to time, can you also look at this data and extrapolate information about continuity of mental health care providers? That is something that we've been talking about for a long time. I know that you've done a lot of stuff on this. It is intuitive to us who are not healthcare providers that would be a big deal. That would be a very positive step for folks to see the same person a couple of times.
Sure. That's actually why when we talk about cancellations, where we may in fact cancel a mental health visit. If somebody has a mental health encounter scheduled today, but the person that saw them 2 days ago or a week ago or 2 weeks ago is going to be in tomorrow or the next day, we may cancel that encounter. Mental health, more than the other services, really strives to accomplish that. So Dr. McDonald and the medical services also work really hard to get that same level of continuity into our chronic care encounters for asthma, for diabetes. But the mental health service has been out in front, and it does account for some of the cancellations we see.
Thank you.
For the specialty off-island, on-island specialty, we seem to be hovering around 40% for off-island. What is the target that you're shooting for? You have these daily huddles. Cassie talked about some of the new systems being put in place to increase efficiency, increase collaboration. What are the indicators you're striving for? What would be, given the nuance of the system on cancellation, what standards are you being measured by?
We're striving for 100%. We want to make sure everybody's there and getting the service. We're definitely seeing variability across facilities. I think one of the facilities that we're focusing on right now, one of our lower performing facilities might be GMDC. So what we do is, because we're able to see the variability in facilities, we talk about what other resources does the staff need to make sure people are getting access to care. And that's one of the things that we will continue to look at as we work on our plan together.
Just on that point, we've talked also, you and I, and Happy Valentine's Day, about better transportation systems, particularly with regard to Bellevue. Is that getting better?
Yes, it is, thanks to Chief Jennings, who is in charge of transportation. And those of you that don't know her, she is on the phone earlier than I wake up in the morning on the radio, talking to people, making sure where is the bus, where are they, how many people are on there, are they getting there, and everybody knows they must be accountable. But I think it's one of the things that we've done that we're going to talk about. How do we make that an even more robust resource available to enhance the service?
Patrick, did you mention when you're coming back with the plan?
So I think the plan is, next meeting we'll come and report to you on what our progress is in the plan. I think this is going to take a course of several months for us to, I think, figure out exactly what we want to track in terms of data, what we know about the process itself. We want to be able to prove that a lot of, whatever we decide to do in terms of workflow changes, we're going to be able to prove through data that these changes are actually taking effect, a substantial effect in the service itself. So I think next time we meet, we'll probably have a better idea of when this will be done.
Thank you.
So as you know, we have two variances to consider at today's meeting. Before that, though, we're going to have a question of time for public comment. The board will first vote on the new variance for 18 to 21-year-olds, and then on the replacement variance for 18-year-olds. But first, we will hear from the public on the department's February 9th request for a variance permitting it to house young adults ages 18 to 19 to 21 in ESH. We have 6 speakers scheduled to speak. We'll ask that the speakers limit their public comments to matters relating to the upcoming votes. The board will have additional public comment period on other matters at the end of this meeting. Public comment will be limited to 4 minutes per speaker. The iPad on the stage will tell you how much time you have left. The first speaker is Mark Cranston.
Mr. Chairman,
Yes.
I've been a member of the Board of Corrections for 16 years, and during the 16 years, I have disclosed many times that Mark Cranston is my cousin. It has been suggested that I have not disclosed it recently. There are some new board members, and I welcome them. I also often don't agree with Mark, but I can tell you this: everybody in my family and I are very proud of him.
Thank you, Michael.
Don't take that away from his 4 minutes, please.
The clock didn't stop.
You have 2 minutes left, Mr. Cranston.
Thank you. Good morning. I will definitely comment on the variance. I'm Mark Cranston. I'm the advisor to Elias Sousa Medina and the Correctional Officers Benevolent Association. I will definitely comment on the variance, but we'd be remiss if we didn't single out James Perino and his appointment to the Board of Corrections this morning. As many of you know, the COBA has taken the position for a while that there should be at least one member on the board that has served as a correction officer at Rikers Island, and we welcome Jimmy, and we definitely look forward to meeting with you and talking to you as we have with many of the other board members, and we will continue to do that. We will say that Jimmy's appointment is welcome, but it's not a replacement for the voice of the Correctional Officers Union, and we will continue to have a dialogue with all the board members in an effort to solve some of these very serious concerns and problems that we have. As it relates to the variance, we'd just like to point out that it seems every month that we come here, there's some form of a variance that is on the table as far as the 18 to 21-year-old population. We reiterate our position from the beginning that eliminating punitive seg as an option in very limited circumstances was probably not the way to go at the time, because I don't think the infrastructure was there to handle some of these very troubled individuals. And although we don't subscribe to the fact that punitive seg is the answer in any long-term strategy, we do recognize the safety concerns, and we see them every day. And in an effort to keep inmates safe and an effort to keep staff safe, we would like for the board to consider just following the federal guidelines as it relates to punitive segregation until such time as we can create different spaces and safer environments. I know the commissioner and the chiefs and everybody are working very hard on trying to create that atmosphere, but we still see that their hands are tied in the sense that there are a very small number of individuals that cause significant damage to other people and create violence on a daily basis. And those individuals need to be taken as exceptions and dealt with differently than the rest of the population. We don't subscribe to punitive segregation as any kind of answer in any long-term situation, but we do see on a daily basis the havoc that is brought to quite honestly, mostly other inmates. And we want to protect people, and it's our duty to do that, and we find it very hard to do that without having that as a tool. So we ask you to consider that. I know you're going to rulemaking in the next year over punitive segregation. We certainly want to be involved in every aspect of that conversation, and most importantly, in every aspect of the solutions to it. We have a level of expertise that we want to lend to you, and we are very encouraged over the last month with the conversations that we've had with many of the board members, and we look forward to continuing that dialogue on a weekly basis if possible. But we want to reiterate with the variance requests, it's rather confusing, quite honestly, for people that are even in the know and the correction officers on the ground. They're not even sure what the rules are at this point, and they really need to understand that the board and the department are working jointly to try to clarify that stuff and keep everybody safe. So thank you, and again, Jimmy, welcome.
Thanks very much. Next will be Mark Steyer.
Good morning. As you know, I'm the Director of Legal Affairs for the Correctional Officers Benevolent Association. I don't think that I've had the pleasure of actually addressing the board for some time. Speaking on the variance request, part of it, and I'll read it, texto, is that a young adult can only be placed in ESH entry housing area if the person has recently committed and or participated in an actual or attempted slashing or stabbing. I'm going to stop right there. One of the ways in which boggles my mind that we don't have the scanners that were purchased, the RAD per Secure Pass scanners that have passed judicial muster, merely because the Department of Correction doesn't have technicians. So for want of a handful of people who are trained in the use of these, they're mothballed. You wouldn't need to put people in enhanced supervised housing of any sort if you caught the weapons. And this is something which should mostly really concern the inmate advocates who are opposed to the use of punitive segregation as a tool to separate dangerous people from population. So I ask legally, that's what my job is as a lawyer, that the Board of Corrections make an inquiry into the alleged state law that bars, which it does not, the use of these scanners. And if, in fact, I'm right, and we'll be following up with a letter to the board's counsel about why we think this is the case, then perhaps we can all agree that the jails can be a smaller, safer, more humane place with detection and with that prophylactic solution of catching the contraband, these scalpels, before they are used to open somebody up. Very simple. I thank the board for its attention, and any questions, we'll be in touch. Thank you.
Thank you. Next speaker is Al Craig.
Good morning. First of all, how you doing? Glad to see you here. What I came this morning to speak about is reasonable expectations of employment, right? I've been hearing so much from people that know absolutely nothing about the job we do, that having urine thrown on us, feces thrown on us, being cut and assaulted is a reasonable expectation. It's not. I worked there for over 20 years, and it just did not happen. Now, with these rule changes that the commissioner has put in place, they've led to this. They've led this type of environment that people are getting hurt. This become now it is reasonable for us to get have these things happen to us. And, you know, it's really disheartening as an officer to hear people try to rationalize feces and urine being thrown. They're throwing it because they're upset. They're not getting services. I mean, every excuse in the world why they're committing these violent acts. The commissioner, in a few months or years, a year or so, is going to be leaving. And he stands up here and he says to people, the biggest thing about this legacy is that I'll stop punitive segregation. There's an officer in Delaware who was murdered. And this type of environment that the commissioner has set happened, the same thing happened in Delaware. George Motion is the last correction officer to die, to get killed. We have a building named after him. Culver is not trying to have any more buildings named after dead officers. The reality is, 3 months ago, I got up here and I was quite angry and I spoke about inmates hiding razors in their rectums. 3 months later, the commissioner comes in on the news and says, oh, they're hiding razors in their rectums. And everybody's shocked in this room. All the media is, oh, wow. Nobody won't listen to Cobra. We know what we're talking about. The bottom line is, we said it, and he reacted slowly to this. The reality is, everybody in here, some of you care, and some of you don't give a damn. That officer who died in Delaware, is gonna, we're setting this up. And he's gonna kick this can down the road, and he's gonna be long, and the next guy who's sitting in that seat is going to be the person that's taking the weight for the officer getting killed. So nobody's gonna wanna hear these sad songs or any speeches from the mayor. Nobody wants to hear that. We got the opportunity to do something about it right now. Let's do it. People might say, well, you're throwing him under the bus. Commissioner, let me tell you something. We do not want to bury an officer who's going to get killed in our jails. We don't. And you're only going to be here for a little while, maybe for 10 years, who knows? But you have the opportunity to do something about this. Don't come up here and just espouse stats. You've told people that there's 9,000 inmates on Rikers Island, and there's 4,000 or so uses of force. That's a lie. That is an outright lie. We process 60,000 inmates. See, when you hear 9,000 and then you hear 4,000 uses of force, of course, that makes everybody in this room go, wow, that's a lot. But when you hear 60,000 inmates came through Rikers Island and over 50,000 went home without incident. And what do? We sit in this room, many of us just looking for a story. We're looking for a story to tell, an experience to have, and we don't really care about these black and Hispanic kids. We don't care about the black and Hispanic officers. Let me tell you something. This month is Black History Month. I'm well aware of what black history is. The reason why I'm on this job is because of Attica riots. The Attica riots, one of the conditions was that they hired black officers that looked like the inmates because they believed they would treat them more humanely. And the fact that 50,000 went home without any incident shows that they were right. So when we keep sitting here thinking that we don't care about these inmates, what do you care about? Where's your conscience? Where's your conscience? When I'm sick and tired of walking around here not hearing officers, you're not even hearing us. 3 months ago I said this, and everybody's shocked. Oh, now we need metal detectors. It was not even addressed after I said it from this department. Nobody got up and said, well, he's right, we need these metal detectors. But now you got to cover up for the fact because you set these conditions where somebody's going to get killed. So now, we need the metal detectors. People, you're responsible. You're responsible. All of you in here are responsible for what happens every time an inmate or officer get cut. Work with us so that nobody's getting cut. Stop bull crapping. That's what you need to do. I asked a lady last time I was here for a card so we could talk from legal aid. And she looked at me and said, what? Why do you want my card? Why do you want to know my name? I sat there and shocked. shouldn't you, if you were a plumber, if you needed some experienced person to try, if you really wanted to help things, you would be willing to deal with anybody. COLA is willing to work with anybody in this room that's willing to make it better. And another thing, this 21-year-old thing, let me tell you, in our society, we've determined that your freedom ends when it impedes upon the freedom of others. We say that. That's what we live by. And now we sitting here, and the perpetrator of these things are now we advocate for the perpetrator. If you care about the inmates, if you say you do, other than a job and a check, see, that's what it really comes down to. If you really care, you know what you'll be saying? Hey, I'm willing to work with anybody to make sure all inmates are safe. So once again, in the spirit of Black History Month, I would like to thank the inmates, the 43 lives. I respect the 43 people who gave their lives for me to have this opportunity to come up here and tell you what it really is. I look around this room and I see a lot of Caucasian people. Straight up.
Mr. Lang, I think you're right out of time.
I am, but I'm going to say this and then I'll get out. I see a lot of you, and that's great. That's beautiful. And in the spirit of trying to make things better, that is great. But you know what? These people gave their lives so that people like me can have this uniform, and we do treat inmates humanely. And we're not ever going to stop doing that. And with your help, we can make it better. Thank you.
Next we'll hear from Sarah Kerr.
Morning. My name is Sarah Kerr. I'm an attorney with the Prisoners' Rights Project of the Legal Aid Society. I commented in January how far this process has strayed from the original concept of ESH, a place where young people and individuals with serious disabilities or conditions were to be excluded. I ask that you remember the requirements that were put in place by this board before you consider obliterating those standards adopted in the rulemaking process through the use of this one-sided variance process. The department asserts that it is doing things that haven't been done before, and then asserts that there is data and evidence and critical need to adopt policies through the variance process with no evidence-based support. At the same time, they state they are doing things they've never done before. They assert that many other jurisdictions use the restraint desks, but provide no comparisons of criteria, the policies, the reasons, the length of time, or the conditions of their use. Using the variance process to create another restrictive unit suggests no limit on the department's ability to evade the board's standards and proceed with major changes in the city jails, absent informed input from the public, absent finalized policies, and because the policies are not finalized, absent a trained staff. You do not have informed input from the public because the department will not share current policies concerning ESH and other restrictive housing units, will not share data or statistics, has not provided the question asked during so-called assessments, and has not shared the classification directive. I continue to fear that the so-called assessments are interrogations conducted in violation of the right to counsel and the right against self-incrimination. The possibility of serious constitutional infirmity should not be taken lightly. Creation of restrictive settings through variance is a disservice to the individuals housed in the jails. There are no consistent rules, no consistent message from staff, and no certainty of what will happen to them. The proposals contain timeframes that are excessive. 30 days for an assessment plus 45 days if you are placed into ESH after 30 days in the entry unit. That is wholly inappropriate. 75 days for anyone to be held in the humiliating restraint desks for all out-of-cell time without review. Why is there a need for the entry unit? Who gets into the secure unit instead? How do criteria differ between these settings? What evidence indicated that the secure unit model without restraint desks would not suffice? In New York prisons, the restraint desks are used in some of the residential mental health treatment units. In each of those settings, there is a treatment team consisting of mental health staff and a unit team consisting of mental health and security staff. Those teams reevaluate restrictions on a daily and weekly basis. Moreover, the chairs were not designed for the long hours that are being used in the ESH. Here, for individuals not yet convicted of a crime, the DOC wants to normalize this extreme measure and consider a less restrictive alternative only every 45 days. Despite the incredible traumatic histories of many of the individuals being placed in chains for hours on end, you are normalizing traumatizing them again if you vote yes. And let's be clear, there are individuals in these units, including young adults, who will tell you that some staff tell them that they will never get out of these restrictions. This is not just the lack of a clear path of progression out, it is the outright denial that they will ever be able to escape the harsh, humiliating conditions in the ESH. We have heard that young adults housed in blended ESH units are told that there is no capacity for them to attend school, yet we hear nothing about concern for this failure from the department. There are individuals with serious behavioral health problems and young people for whom 45 days is unrealistically long, gives them no hope, and is just plain cruel. Look at the department's request. Quote, all inmates placed in ESH can advance through each level with consistent, productive program participation and good behavior, end quote. How is that measured? What is productive participation? How is that being measured? What is consistent? Daily? 45 days without a bad day? HHC should assist the department in adjusting the carefully formulated seclusion and restraint rules of hospitals to any use of the restraint desks in the jails. The hospital rules require that such mechanical restraints shall be used only in extreme situations and then for the shortest time possible. They recognize that the use of mechanical restraints is humiliating, counter-therapeutic, and traumatizing. To claim that the DOC's proposed use is non-punitive is false. Chains that are reminiscent of bonds of servitude and slavery are not a measured response that should be contemplated for our jails at all, and certainly not without protective measures in place. I'll skip the rest. I proposed appropriate restrictions when I testified in December of 2015. You've had proposals for what kinds of things should be in place, including HHC participation, and I ask you today to please vote no and to put this into rulemaking.
The next speaker is Jennifer Parrish.
Good morning. My name is Jennifer Parrish, and I'm the Director of Criminal Justice Advocacy at the Urban Justice Center's Mental Health Project and a member of the Jails Action Coalition. The department manipulated this board by withholding its variance request at the January meeting, and then the very next day, invoking emergency and variance provisions to circumvent the board's scrutiny and to carry on with the practice that it recognized the board opposed. I commend the board for issuing a notice of violation, and I hope that you will scrutinize what the department tells you going forward, as they have demonstrated that they have no respect for the board's rules and process and will act with impunity when they so choose. I hope that each of you has been to the Young Adult ESHU unannounced, not as part of a DOC orchestrated tour, to see for yourself the department's violation of the standards and to enable you to question their claims about how these units operate. I urge you to deny the variance requested by the department today. The variances permitting young adults to be placed in enhanced supervision housing cannot be lawfully granted. When the department requested a variance to create ESH originally, this board recognized that rulemaking was required and that such a change in the minimum standards was not a legitimate variance request and denied it. This situation is no different. During rulemaking, in which the board heard from experts regarding the neurological development that is still taking place in young adults into their early 20s, the board adopted a standard which specifically excluded 16 to 21-year-olds from ESH. units with 17-hour lock-in time. There were good reasons to exclude young adults when you adopted the rule permitting the creation of ESH. Now there are even more reasons not to allow young adults to be placed in these units. The isolation that occurs in ESH is significant. For 17 to 24 hours a day, people are confined in their cells. Such isolation is harmful to the physical and psychological development of young people. When young people are allowed out of their cells in the newly created ESH entry unit, where 18 to 21-year-olds will spend 30 days to be assessed and then placed in an ESH level 1 for up to 45 days, they will not be permitted unfettered movement throughout that time, but are instead chained to a restraint desk. The health risk associated with shackling young adults for extended periods of time have not been adequately addressed. This variance includes no assurances whatsoever that young adults will be assessed by health staff before entering into this unit to evaluate their mental and physical health to determine whether extensive periods of shackling and restrained movement prevent specific health risks that require them to be excluded. The use of these restraints was not part of the ESH plan that was presented to this board. The board has never approved such restrictions of movement during out-of-cell time, yet it is being used in the ESH routinely and on young people. Moreover, the department does not adequately justify the need for 30 days of assessment. Isn't it actually just a substitute for punishment in lieu of solitary confinement? Whatever else happens in these individuals' incarcerations, they will be punished with this cruel trek from 17 hours of isolation in their cell to forced seated restraint. What happens during this assessment, if that's what it really is, that makes 30 days necessary? Has the board observed these assessments? Or whether they could be completed in a few days or a week? Even after the assessment, young adults may remain in ESH Level 1 with continued use of restraint disc for unlimited time. The department does not explain how the programming offered in ESH Level 1 counteracts the punitive nature of the unit. Isolation is known to result in people being placed there becoming more violent, not less.
Ms. Parrish, your time is up.
Thank you, but I just want to remind the board that in March of 2015, the department was selected by Vera Institute to look at segregation alternatives, and Commissioner Pont made a statement about how this was necessary. If Vera Institute of Justice, with all its expertise, thinks that these restraint desks are a good alternative to solitary confinement, this board should know that, and if they don't, you should know that as well. Thank you.
The next speaker is Kelsey Diavola.
Good morning. My name is Kelsey Diavola. I'm the Jail Services Social Worker at Brooklyn Defender Services. BDS continues to urge the board to reject the department's request for renewals of the variance permitting young adults to be housed in ESH. We have raised time and again the reasons the board should reject this continued variance, highlighting the board's own commitment in 2015 to protect young people from detrimental impacts of solitary confinement and ESH to their health and development. Despite the board's stated intentions to exclude young people from extremely restrictive conditions in ESH, it appears the department has only accelerated placements and made conditions even harsher by introducing restraint desks. The board must take action to preserve the integrity of its rules and the dignity of young people in city jails and reject continued reliance on punitive measures undertaken without due process or even written policies, at least none made available publicly or to the Adolescent Young Adult Advisory Board. BDS categorically opposes the creation of yet another restrictive housing unit designed specifically for young adults, the ESH entry unit. We share the department's concerns about safety for all people in the jails. That said, the evidence suggests that the proliferation of new restrictive units has had the net widening effect advocates feared and voiced months ago. When solitary confinement for young people was ending, numbers dwindled to 7 in isolation and less than 10 in secure. Now there are dozens in ESH and secure, not to mention true and true. The department's letter describes operational changes in ESH, which suggests that individuals would spend a minimum of 180 days in ESH. moving from stage 1 to 4 in 45-day segments. With young adults, the letter suggests the stay would typically include an additional 30 days in the ESH entry unit, making the fastest probable release from ESH a staggering 210 days, more than 6 months. The department describes that the 30-day ESH entry unit placement is necessary in order to conduct a comprehensive assessment and information gathering involving all stakeholders. Regrettably, no information is provided explaining why such an assessment would take a month, what criteria are used to conduct such an assessment, nor who the stakeholders involved in the decision-making process are. Also unclear is what is meant by information gathering and how this process factors into a young person's progress toward less restrictive settings. Nor is it established how proportionate enhanced security measures dependent on the inmate's actions and histories are to be determined. Clarity in written policies and procedures on these matters should be provided before opening new units, not months or years later. Furthermore, BDS is extremely concerned about the use of restraint tests in ESH and elsewhere, and we urge the board to evaluate how the use of restraints may violate due process protections related to enhanced restraint status. We also request for H&H to provide input as it relates to the use of restraint tests. Young people, more than anyone, need space and opportunity to exert themselves, beyond a walk to the telephone or returning to their cells. We question the appropriateness of such measures for this population. Finally, the department's claim of a, quote, good faith effort to fully comply with the applicable provisions of the minimum standards rings false. The department withdrew their previous variance request regarding this matter before it could be discussed at the last public meeting, engaged in unacceptable contemptuous tactics by submitting disingenuous emergency variance requests, and blatantly remain in violation of the minimum standards until submitting the new request on February 11, 2017. This is a far cry from good faith. For the reasons outlined above, we urge the board to reject the variance requests. Thank you.
Thank you. So now, first I'll ask that before we come to the variance, we'll ask the department for an update on the young adult plan.
Before we give an update, I just wanted to address some of the comments regarding the body scanners. I just wanted to make clear that the public health law, just for clarification, the public health law allows the use of body scanners for only diagnostic purposes. It does not permit use of body scanners for security purposes. So that is really the major obstacle to our ability to use the body scanners. We are seeking legislation on that issue, as the board is aware, and we appreciate the support. Thank you.
Just Patty, could we have our council and outside council look at that issue? That's a big piece of business there.
Absolutely, we welcome that opportunity.
Okay, thank you.
Good morning. Thanks for the opportunity today to talk about the young adult plan and kind of what we've done over the last few years and how we envision the agency moving forward. I'd like to welcome Jane Farino to the board, somebody I had an opportunity to serve with over a couple of years in my time with the New York City Department of Correction. I know he'll do the city a great service, and I know you'll earn every penny of your salary on this board, so just don't pay. So start with, we have a few slides, we'll go over those. We have several presenters to try to add clarity to what we're doing with the young adult plan and what we're doing with young adults in particular. First slide has to do with kind of talking about the difference between where we were in 2013 and where we are today. So as we move forward, both from the elimination of punitive seg for 16 and 17-year-olds in 2014 to where we're at today on how do we then change the behavior of people who come into our system and act in a very violent way. So our young adult strategy, we've gone through all the options. We think we have a reasonably good plan in place to address now in a less punitive way, how do we modify behavior that keeps these young adults safe and keeps our staff safe. Well, we said it before, our commitment has allowed us to drastically reduce our use of punitive seg. So our next slide will give you an overview of where we've been and what our punitive seg numbers are today. Just over 1% of our population is now in punitive seg in comparison to 2% if we look at all restrictive housing units. Nationally, that number is about 4.4%. So we compare very well in the use of punitive seg only for those that absolutely require it. Now, we're not done addressing the needs of different populations. We have built several options, and as we have ended punitive seg. The process for us has been fluid. So as we've looked at options, and we started off with ESH, enhanced supervision housing, and moved away from punitive seg. As we've seen in the last year, we understood that some of our options, from secure to second chance through, were all models that worked effectively at certain levels, and obviously we had to have other opportunities or other solutions at the more violent end. We still need options. So slide 3, we still need options on how to address this violent behavior. We don't have a perfect solution, but safety has to be paramount. So as we move ahead in our approach to managing very violent offenders, safety has to be a #1 factor. So while we'll talk a little bit about the use of desks and why we use those, if we don't have a safe environment, and that goes anywhere in our jail system, then we're not going to be able to live with the programs in an effective way to change the behavior of these young adults. And you're not going to do it in a week. You're not going to do that in 30 days. So it's not we're trying to move from a punishment model to a therapeutic incentive model. That's not easy. That's not easy to do, not easy to design. Many of these young people have a level of violence historically, both from the community to inside our jails. That's not going to happen. We're not going to sit down and have a 15-minute conversation and eventually they're going to say, okay, I get it. I'm not going to be violent any longer. It takes a lot of work by a lot of people in order to change that outlook for young people, in order to make so they not only act safe while in our custody, but also act safe when they're released from our custody. Talked a little bit, and Wynette and others will talk about diagnostics, or how we're looking at an individual at 30-day window when we bring people in to evaluate them. There's a lot of information to learn, and in order for our strategy to work, we need to really understand what makes individuals tick in order to make that change. So as we instituted the enhanced supervision housing model, it really was very effective, and we've added the layers to it, the levels. So we now have levels 1 through 4, and we've added restraint tests at level 1. After, again, some very violent acts. We'll actually show a little video today to really show the challenges that we have. So the unions and others have talked about the weapons in our jails. We'll show the chief and Jeff will talk about why that's a problem for us, why these weapons are showing up, why we have a very difficult time finding those weapons. I think support for the bill that we'll submit to the Assembly to change the law so we can now use the systems to make our jails safe will be helpful, but it doesn't really change the trajectory of how do we manage young people. You know, we're on the forefront of the country. No one in the country is talking about fully eliminating punitive seg, period. I mean, that's not even a conversation. We're on the cusp of doing that and finding safe alternatives. You know, we talked about Vera. Vera, has gone across the country and looked at many jurisdictions to find out what they were doing to offer better outcomes for reducing the use of punitive seg, safer alternatives. But no one's saying we'll eliminate it completely. No one's even having that conversation. So we've gone a long ways up front as a city, and we should be there as a city. We should be writing the script for how to manage young people from now into the future. You know, we have legislation coming up to raise the age. One of 2 states in the country that tries 16-year-olds as adults, one of 10 for 17-year-olds. So while we've done a lot, I think we're not on the cutting edge on how to manage young people in correctional environments. The city of New York has come a long ways. I'm proud of what we've done so far. We have to provide a safe environment for our staff in order to provide a safe environment for inmates. Nothing works if it's not safe. So Jeff and the chief will talk about some of the incidents that drove our decisions, and then Lynette will talk about the programs that we think will impact our young people. Thank you.
Thank you, everybody. As the commissioner said, just want to follow up. We've been moving forward on trying to find the appropriate alternatives. And as we said before, we had ESH, and we had initially kind of tiered it as a progressive system so you could earn more time out as you kind of went through the programs. We instituted entry level 1 with the restraint test because of increased acts of violence and the need to be able to honor our commitment to offering program and engagement with inmates while keeping those inmates safe, both from each other, also to keep officers safe in those units. We most recently engaged, we put in individuals who were most recently engaged in slashing or stabbings because we knew at the time that those were people who had recently engaged in an act and we needed to kind of still engage them, move away from a punitive segregation model where they were in their own cell, and as the commissioner showed in his slides, to be able to offer them more than just what was there before in terms of cell study, and I'll have somebody else talk about that, but wanted to show you a little bit more about the weapons concerns we have and why we needed to kind of institute this effort.
Yes, good morning. Before we show the video, I just wanted to just say that we normally don't show video here from the Department of Correction, but this particular video was leaked to a local media outlet, and therefore made public by that media outlet, so therefore we're going to show the video that they had shown. So this is in one of our facilities in the law library. You can see the fellow on the lower left just reached over and slashed the inmate to his face, and the inmate behind him slashed him to his back. So the inmate who did the first slash was an adult. The second inmate was a young adult, and the victim was an adult. Now you see all the inmates involved now. They're starting to reach into their front area, the genitalia, and into their anal cavity to secrete their weapons that they had pulled out. So this is a weapons problem that we have here in the Department of Correction, and that we've obviously acknowledged, and some people have come up and talked about that. So these are the challenges that we face on a daily basis. These are general population high custody inmates. This was not inmates from any restrictive housing. Again, these are the challenges that we face on a daily basis, and we do not have the means to detect those weapons, as we know the inmates are walking around with them, again, in their anal cavities.
While we certainly hope that this is not too graphic, we wanted to certainly highlight, while we've seen improvements in ESH and some of the participation in programming, it is not perfect. It is not a perfect solution. We're clearly trying to figure out models that will work, that allow us to engage with inmates who we have seen engage in violent acts. Moreover, we've kind of done the analysis statistically. Those who do engage in violent acts, serious assaults on staff, slashings and stabbings, are more than 11 times likely than general population high classification inmates to engage in another such event. We have had those events in ESH and in ESH level 1. We had attempted slashings in that, even with the restraint deaths, but again, because we want to continue to commit to programming, engagement with the inmates, we felt this was the safest alternative at this point. Again, to keep away from kind of punitive segregation and the use, but to provide a safe space by which inmates can still engage in programming and engagement and education while also keeping both the inmates and staff safe. So I want to, yes.
Stanley and I, as you know, were out in Rikers Island with you last week, and I think what the chief failed to mention, which was really compelling to me, was that these individuals involved in this video, that's why we're not looking at it, the individuals who are involved in this video, you were unable to find the weapons, even though you had this video.
That is correct. Several people for whom we placed in ESH level 1 shortly after a slashing or stabbing, we could not find the weapon. Much like the video shows, there are technology concerns that we.
So, Mike, to your point, so every inmate, so we responded to this incident, we secured the inmates, we took them to the intake, we searched every one of them, did not find any contraband, placed each individual into isolation, and still have yet to recover any contraband from this particular incident, even though you clearly see on the video each individual reaching.
It just seems to this board member, the issue of this technology and the legislation and figuring out a legal way to do this is imperative and immediately imperative.
Yes, absolutely, we agree.
So even the two inmates that committed the slashing, their weapons weren't found either?
That's correct. No weapons were recovered from this incident.
So good morning, everyone. I want to talk a little bit about what we've been trying to do and the resources and the feedback and the different things that we've tried to do to get to where we are today. So as you may be aware, young adults account for approximately 12% of our population, but are disproportionately involved in violent incidents. So they're responsible for about 30% overall violent incidents across the department. So what we've done is, as well as looking at evidence-based programming, we've also tapped into resources within New York City and some of our stakeholders. As a matter of fact, some of our individuals that were speaking during the public comment have been at our meetings on January 24th and on February 7th to really talk about other options and to ask about feedback on what other ways we can do what we're trying to accomplish. To date, we haven't gotten any response to any alternatives. But moving forward, we're going to continue working with everyone to see what other ideas out there, what other things are being done across the country. So along with age-appropriate programming and really looking at programming that focuses on the reduction of violence and improving behavior, we've determined that, number one, education is our most protective factor for this population. And so we ensure that ESH has the opportunity, all ESH participants has the opportunity to go to school for at least 3 hours. And based on one of our partners' commentary that was said this morning, we did surveys with our young people to really find out, are there additional young people that want to attend school? And because of the need, we have added an additional interval for educational services. So now there are 2 educational service tracks that are offered to young people who are in ESH between the ages of 18 to 21. We also have 4 hours of DLC facilitated programming that is done by our educational specialists and our programming counselors, as well as our reentry planners. So we focus on dialectical behavior therapy, creative arts, youth communication, and interactive journaling. And we basically are expanding on the programming that has yielded some positive outcomes and also has gotten some positive feedback from our population. As you know, this is constantly evolving. As the commissioner and many others know, including Vera, this hasn't been done across the country. So this is not something that's going to stop. It's going to be constantly evolve and be tweaked and modified so that we get the outcomes that we're looking for. As you know, we've added program counselors who work directly with our population to develop and deliver programming. I want to take you through now what the proposed process is. And, did you have a question?
I just want to ask a question
Sure.
about education.
Sure.
I was at ESH yesterday.
Yes.
You did say, the staff there told me that you were adding a second track, but that was, yesterday would have been the first day.
Yes, it was the first day.
It happened before.
It hadn't.
And I don't know if it happened, I don't think it happened yesterday.
As a matter of fact, we had some of our young people that caused the fire and actually flooded cells. So one interval happened and the second didn't because of the behavior.
Because I was there. If the second one happened, I left at 12 o'clock. I mean, everybody in ESH.
2 young people attended school yesterday.
They did, that's great. Everybody in ESH was locked down for the past 3 days. That's when I was there. They were not getting education, they were not getting showers, they were not getting telephone calls. But specifically on education,
yes.
I would like to hear why ESH did not get telephone calls or showers or visitors or education for 3 days. I was told by the ESH, by young adults, that several of them told me that they had wanted education, but they were placed on the bottom of the list. And I spoke to the Department of Education staff who said, yes, they are on the bottom of the list. They're not coming to class. We have too many people who want to come to class, and they're not coming. I was also told that there were only 6 places available. There were approximately 20 people who wanted to have classes. That people, and that so that the majority of people in the SH who wanted to get education were not provided with education. And this program is not new. This has been going on for months. So it's just difficult for me to understand, your programmatic commitment when you have no programmatic operations there at all. And additionally, the staffing that you have there. I mean, these are students who require, probably substantial numbers of them at the special ed level, which would be just 6 to 1 teacher plus a para, and that's not the staffing that you have in place. But fundamentally, most people at ESH are not getting the program that you consider to be the most important. So I find that very disturbing when you come to us, as you have periodically, and say, we're doing this, we're doing this, we're doing that, when in fact you're not doing it.
That's not accurate, Dr. Cohen. So let me just give you some background. So one is, previous to the modification to the classroom in 3 South, which is the area in which we call the entry unit at this juncture, it is currently being modified so that we could expand the number of seats. Additionally, we had 8 seats and we only had 6 kids that wanted to go to school. Over the last several weeks, about 20 kids have signed up. Now, there are kids that sign up and don't show up. And so in an effort to ensure that there are seats available for young people, we are expanding the classroom in 3 South. If you've gone to 3 South, you would have seen that the classroom has been knocked down and the tables have been removed because we're putting additional tables. But in the interim, we put 6 chairs on the other side so that program doesn't stop completely. So right now, as of February 13th, DOE was able to provide us. We had a lot of planning goes into this. It's a lot of things in terms of getting teachers who volunteer to come to this area. It's not something that can be done overnight. So although there's a lot of planning that takes place behind the scenes, the first date in which we plan to expand to 2 intervals began yesterday. So I just wanted to give you the actual planning piece and the implementation process. It's not something that's done overnight. What I'm going to do is I want to ask DOE's Senior Executive Director for Youth Justice Educational Services to talk a little bit about what you're talking about, because as you know, these are services that are provided by DOE certified teachers and through our partnership with the Department of Education.
Before he comes,
Sure.
I just have a question for you concerning the increase in the number of young persons who are going to school or wanting to go to school now. Do you have any sense, do you have a hunch, do you have any factual data that helps us to appreciate why the increase?
Well, we did a survey with young people because what we wanted to do is make sure that our young people are getting they see the value in what we're trying to accomplish for them. And so we did a survey, and young people have stated that when they were in other facilities, they didn't really feel safe in terms of the fact that they've done a lot of things when they were in the community and while they were in jail, and they felt very anxious around others. And so the fact that they are in restraints, they feel more comfortable that everyone is in restraints and feel a little bit more safe going to school in this fashion.
Good morning, everybody. My name is Nick Ranacci. I'm the Senior Executive Director of Youth Justice Education and Treatment Programs for New York City's Alternative Schools District. And I'll just talk a little bit about the educational services we're providing at ESH. And I want to give a little context for the educational services that were provided for the population in punitive segregation before we had ESH and restraint desks. So you got to remember, all the kids in ESH, one thing that's important to know about all the students on Rikers Island is 16 and 17-year-olds are mandated to come to school. They're mandated school age. 18 to 21-year-olds are voluntary school age. So they can opt whether or not to come to school on any given day. Even if they sign up for school, that doesn't mean they need to attend or come out of their cells to go to school. That's not only true of ESH, that's true of all 18 to 21-year-olds across Rikers Island. They're just like students in the community. They could come or not on those days. Before, you're totally right, Dr. Cohen, in that the kids from ESH are probably the most educationally challenged kids we have. I'll give some data points about the students who are currently there. 50% of them are students with disabilities, meaning they have an individualized educational plan. They were special education students when they were in the community. 89% of the kids who are currently in ESH dropped out of school before they got arrested and came to Rikers Island, which means that they dropped out in the community before they ever got arrested, and they actually signed back up for school when they were in custody. If they had stayed in the community, they'd be high school dropouts right now. Their average age is 20.5, which means that they are at the very end. You can go to school in New York City up until the end of the school year in which you turn 21. So these guys are very close to the end of their educational opportunities, at least for a high school diploma. And their attendance rate is 44% while they're in ESH, which means, as DC Saunders said, even in ESH, they only attend school a little less than half the time. Now, those numbers sound very low, and they are, and we wish they were higher. However, their attendance rate is actually slightly higher than the attendance rate of 18 to 21-year-olds in facilities without restraint desks. We're constantly committed as the Department of Education to working with DOC to provide the best educational services we can for this population. We do think that the use of restraint desks, at least in this initial data, and we just started this in October, is showing a slight increase in attendance for this population. It's a little too early to see the achievement. They haven't been doing it for very long. However, we know it's definitely better than self-study was. Given that these students so many of them are special education, they really need an in-person teacher. So some sort of remote option, like computer-based instruction or something, which a lot of states and jurisdictions in the country have moved towards, especially for these population, isn't the right answer for a lot of these kids. They need an actual teacher to help them work through the material, especially if they can't read. We do have a fully certified special education teacher in ESH right now, and we did add another teacher who has multiple licenses. So even though most of these students are studying for high school equivalency and their teacher certification is not as required for high school equivalency students, between the two teachers we have there, we cover all the certification areas in case there is a high school student who needs credits. We are considering putting a paraprofessional in there. As DC Saunders says, it's a tough situation for us because we cannot just tell a teacher or a para to go to this area. They have to agree to it. So we need teachers who are willing to go to an area with sort of the toughest students. And the fact that they're in restraint, that seems to, at least for the teachers we have there, gives them the opportunity to perform their work safely. So we'll continue to improve, try to get their attendance improved, and be glad in the future to share data on how well they're doing.
I guess you have a question. Sure. The department knocked down a wall that existed in the other unit, and there's no wall plan as far as I know for the current unit. I would be concerned, and I believe your staff are concerned, that they're going to be providing education not in a classroom, but in the middle of a day room, which is underneath tiers of where young adults will be. So, don't you think that you should have a classroom to provide classes rather than an open space in the middle of a day room underneath? We've all you have too. Those of us who visit this place know that it's not a quiet environment, for providing education. So there's no discrete space. Additionally, since you're talking about 20 to 24 numbers, that's what I heard yesterday about people who want to be in classes, then the two units will not be enough. There'll need to be 3 or 4 depending upon attendance. And is the city prepared to provide the 611? Just 6 kids, 6 students, for 1 certified teacher with one paraprofessional as the staffing for the programs that you're running, as you would like to.
Yeah, so it's interesting with the different 6-1 ratios and the special ed ratios. We actually don't always provide the same ratios as in community schools in any special education services on Rikers Island for security needs and others. So that's sort of a separate issue about the ratio. We think
the department would facilitate whatever security you need.
Yeah, we definitely can. We think that with the 2 sessions, given the attendance rates of the students, they don't fully attend every single day. So with 2 sessions able to come out, and I think we'll have either 10 to 12 desks we'll be able to cover. There's currently 21 students who sign up for school. are signed up for school. So with the 2 sessions, we should be able to cover those needs. And again, we are working on getting a paraprofessional there for additional support as
I mean,
well.
for example, the day that I was there, there was one student, one teacher, and a security officer assigned. The young man was not agitated. The young man was pleased to be in this setting. The young man was, and the day that I was there, Stanley and I were told that the construction and the changes being made are to prevent the reaching and stabbing potentially of chairs that are too close to each other.
And why the 44% attendance?
Could I add just 2 things? So 2 things. One is, I just want to clarify one point. So the 44% rate of attendance is within ESH, and the 33 is within general population. Because young people 18 to 21, it's not mandated. They choose to come or
So
they don't.
refuse to go.
They don't feel like it. Today I don't want to go. Today I don't want to go, or today I have court. I'm going to have well, that actually hasn't been visits really, but it could be visits, it could be a number of different things. But the one thing that I did want to mention, just to your point, Dr. Cohen, in addition to what DOE has done for us, which we're very appreciative of, is we have also enlisted the help of other community partnerships through PD Green, which has a lot of students who are graduate and undergraduate from Columbia and NYU who actually come in to do one-on-one tutoring with our young people because we want to fast track it. We have a couple of people.
St. John's, never forget St. John's.
I'll never forget St. John's. St. John's as well. But we want to make sure, especially that our young people who are reaching that age of 22 get in all the education they can possibly get in, because some of their goals are to get that high school equivalency. So we've added additional support aside from DOE's educational instruction.
Just with the, still don't understand why people who are not in ESH1 or in your new unit have to be restrained to get education, which is what you're requiring right now. You're only providing education in open areas in a day room with restrained chairs. Even for people who are not in your classification requirement restrained chairs.
So as you know, and as we just mentioned to you, the young people, even when they were not in ESH, did not go to school. Most of the people that are going to school now did not go to school when they were in other facilities. And the average, I would just tell you, the average length of stay that most of our young people have is well over 180 days. So these are individuals who have had ample opportunity to go to school while they were in GMDC, but have not chosen to for their own reasons, and have chosen to now. I think I'll, want to go back to this?
Yeah.
Okay.
Just to finish up at least this public presentation part of it, it's just that I think as Wynette and the Commissioner said, this is a model that we are trying to develop. We have, at least for the restraint desk specifically, taken a look at other jurisdictions. We have contacted people, and we've tried to put the board in contact with people who are starting to take a look at this. This is an effort where, as someone had mentioned, they're focusing both on violent offenders, alternatives to solitary and punitive segregation, as a therapeutic method for kind of mentally ill as well. These are all options that people are exploring across different jurisdictions, including California, Washington State, even as someone said, New York State. Maybe a little different on the margins, but people are exploring the use of these for the purpose of engagement with inmates so that they can be used as an alternative to solitary and long-term punitive segregation type settings. More than 36 jurisdictions that we've taken a look at have some form of use, and we're going to continue to develop this with the board. I think as we've made a commitment several times to take a look at this, we know that it is not a perfect solution. At the same time, we want to honor that commitment to ensuring safety. So wanted to at least offer that to all of you as we kind of move forward with this. Part of the reason we were asking for this variance is to be able to engage with the inmates and meet our commitment to kind of offering the education and programming to each of our inmates.
Would you help us to create a visual of what the restraints actually look like, and how restraining is it?
Yes.
So, I don't know if you can go back to the video. So this is a typical ESH entry-level housing unit. So these are the restraint desks. So the inmate comes out restrained about the ankle, sits in the chair, and there's a device underneath the chair that the officer uses at the desk level to restrain the inmate. You see the individual there. And then the hands are free for the inmate to participate in the programming and the educational service that take place during the hours that the services are provided.
Do they have any movement with their feet?
Excuse me?
Do they have movement with their feet?
Yes, they can move their feet. If they chose to, they can stand up. Their arms are free, as you can see. So this individual actually is participating in the program. He's requested an option, so we're affording him the option now to go back to his cell. And as you can see, the desk here, what Bobby was talking about in housing area 3 South, where we had the classroom, those desks were very close to each other, so we went to a different housing unit and spaced the desks further apart, so there's less of an opportunity for the individuals to actually reach out to each other during the program service.
I know Steve, but could you explain why people didn't get phone calls or showers for 3 days?
Excuse me?
Could you just explain why people in ESH did not get phone calls or showers or visits for 3 days? Or maybe more. I don't know if it's been resolved yet.
Today, 2 units will be locking out as we speak. The other 2 units will continue.
It was 4 days that they didn't.
Yeah, so we locked down the ESH level 1 based on the number of violent incidents that had taken place. So we can search, change out the inmates' jumpsuits, and reevaluate, opposition trained staff, and to again have ESU come in along with facility staff to search the units.
Again, isn't that routine correctional practice that when you have an incident and violent incidents on units that you lock it down?
That is a routine response to a violent incident, yes.
Correct. It can be locked down for up to a week and 2 weeks, depending on the incident, correct?
That's correct.
That's
Yes.
right, thank you.
So again, the whole purpose is to make it safe for both staff and
Have you
inmates.
ever locked down the facilities for 1 to 2 weeks?
We've had long durations of lockdowns. I'm not going to say that it was 1 to 2 weeks, but we've had numerous days of lockdown periods in some facilities, yes.
Correctional institutions around this country have traditionally locked down units if there has been an incident on their unit that is violent.
That's
That
correct. I
happens
believe
across the
so
country.
not to get off topic, but I believe Joliet, Illinois was locked down for approximately 23 years after 2 correctional officers were murdered on the same day. So,
Right, no, right, but you wouldn't have done that. I mean, you would not have run Marion that way, would you?
excuse me?
You would not have run that facility.
No, I'm just telling you that correction practice on that's the extreme measures that facility chose to take. So I'm just letting you know that a basic response to a violent act in a correction facility is to lock it down until you can ensure the safety of everybody that goes through that front gate or comes through the intake.
But I'd just like to add on that we did find significant issues as we looked at the incidents, that we had to do some physical modifications, some training of staff was deficient. So we saw some stuff that we fixed in order to get back open. That's kind of the chief problem.
So if that concludes the report on the young adult plan, I think we can now turn to the 2 variances. I'll provide you with some background. The background on the 2 variances are as follows. On July 12, 2016, the board first granted a variance from the minimum standard 1-16C12 to allow the department to house 19 to 21-year-olds in ESH. The board renewed the variance on October 11, 2016. That variance expired on July 11, 2017. The department subsequently declared some daily emergencies, noting that the emergencies prevented it from complying. On January 20th, the board sent the department a notice of violation of minimum standards, stating that the department had not demonstrated an emergency situation, and therefore the department's continuing operation of ESH for young adults ages 19 to 21 was in violation of the minimum standards. Since the January board meeting, Many board members have visited ESH units for young adults and have further discussed with the department leadership and board staff the young people housed there. Additionally, the board has provided significant comment on the department's new draft ESH directive, and the department has incorporated the board's recommendations and feedback. This process continues, and some of these discussions will be central to the board's rulemaking on restrictive housing, which we hope to commence shortly. In October of 2016, the board also approved a variance that allows the department to house 18-year-old inmates in ESH. This variance is in effect until April 11, 2017. The board believes that the use of ESH for 18 to 21-year-olds constitutes a single issue and so should be treated as a single variation from our standards. Further, the standards refer to 18 to 21-year-olds as a single young adult cohort. Thus, going forward, the inclusion of 18 to 21-year-olds in ESH should be considered as one variance request. We understand that the department agrees with us. In order to align the time frame of board authorization and conditions of young adults currently in ESH, the board will consider the department's February 19 variance request as two separate requests. First, we will consider a variance renewal request for a 6-month variance permitting the department to house young adults ages 19 through 21 in ESH to expire on August 14, 2017. And second, we will consider a 6-month variance request, also with an August 14, 2017 expiration date, to replace the variance which currently expires on April 11th and allows the housing of 18-year-olds in ESH. If the board votes to approve both variances, and if in advance of the expiration of these variances on August 14, 2017, the department continues to believe it needs a variance to house young adults in ESH, the department may at any time request a single variance permitting it to house young adults ages 18 to 21 in ESH. Now I'm going to ask the department to present its variance request for 18-year-olds and for 21 to 21-year-olds. As I explained, the board will consider this as two variances and have two votes. First, the board will decide whether to grant a renewal variance for 18 to 21-year-olds, and then the board will decide whether to replace its current variance for 18-year-olds with one that matches the conditions and time period for the variance request for 19 to 21-year-olds. So we would, Chief, if you want to present the variance request.
Yes, so thank you. So everything you've read, Derek, we do agree, but I'll just read the. So pursuant to 115 of New York City Board of Corrections minimum standards, the department requests a 6-month renewal of the limited variance last granted by the board on October 11, 2016, from the BOC minimum standards 116C1 Section 2, which requires that as of January 1st, 2016, inmate ages 18 to 21, provided that sufficient resources are available to the department for necessary staffing and implementation of necessary alternative programming, be excluded from the placement in enhanced supervision housing. On October 11, 2016, the board also granted the department a 6-month limited variance from the BOC minimum standards 116C1 Section 2 to allow for the use of ESH for 18-year-olds. This variance is set to expire on April 11, 2017. Both variances are applicable to the same provision of the minimum standards, and the department's intention is to utilize ESH and ESH entry units for all young adults 18 to 21 years old in the same manner. The department is therefore requesting that the variance granted for the 18-year-olds be amended to conform to the variance applications set forth herein. This modification would be instrumental in the advancement of changes that are underway for the use of ESH as part of the evolving young adult plan and the management of this population.
Thank you. Is there a board member who would like to move the variance request?
Move.
Is there a second?
Second.
Thank you. Now I'd like to open up the floor for debate and for any questions or issues anyone wants to raise, and also for any member who wishes to propose a condition. If there's any member who wants to propose a condition, please state the exact wording of the condition. Any conditions?
Yes. Yes, like to propose conditions.
Yep,
But
please.
before we do the conditions, can we get to questions or should we?
Yeah, questions first? Fine.
So, on your proposed EHS for 18-year-olds, you're going to have EHS entry and level 1, and both elements will have restraint desks? Because it wasn't clear, or you're going to have ESH entry is the one that has the restraint desk, and then from there they go into the various levels of
So the
ESH.
entry unit will be with the restraint desk.
Say it again?
Entry unit. will be
Just
with
the entry unit.
Sorry. Restraint desk will be an entry unit as well as ESH level 1. After the entry unit assessment, they can be placed in any number of places based on how the assessment is done, whether or not they go to secure or entry level 2, ESH level 2 or ESH level 1.
And could you tell us how many people moved in EHS? What's the percentage of people that moved from like level 1 to level 2, level 3? Do we have data on that?
We currently have 11 young people at level 2.
Mm-hmm. How many people have moved from level 1 to level 2? How many people are moving through? Because the concern is that people will get into level 1 and they'll be stuck there.
Well, all of those have moved from 1 to 2, if that makes sense to you.
So all 11 were started in level 1 and they're...
As a matter of fact, no. As a matter of fact, 7, 8. 8 started in the entry, and 3 started at level 2.
Oh, so
Yeah.
3 went back into level 1.
No. So, I'm sorry. 3 started at level 2. We had 3 that just started at level 2. And others went from entry to level 2.
So just for clarification, so I'm ensured that I understand as well as everyone else. At entry, there are restraint desks. At level 1, there are restraint desks. At levels 2, 3, and 4, which are graduated levels, there are no restraint desks.
Has the monitor opined on the use of these chairs?
Yes, the monitor has and supports the use of the chairs, as I understand. Yes.
Question. I believe that there are people in ESH1 status who were admitted to ESH before the entry unit was established, that have been there since, for months in ESH1 status. Isn't that correct? Are there people in ESH restraint status? For me, they're ESH1 and ESH admit are both ESH restraint units. Every week we get a new unit established there. But right now there are 2 units where people are restrained 7 hours a day when they're not in their cells, if they come out of their cells. And my question is, are there young adults who have been in ESH restraint units for more than 30 or 45 days? For more than 45 days. Which I believe was the question you were asked before.
I'm not sure what you're asking, but what I want to do... Sure, please.
Are there young adults who have been in a ESH restraint status, which includes ESH1 and your ESH assessment units, for more than 45 days?
I don't have the number on that, but I don't have the number on that because what I was focused on was the entry unit to moving forward. But I do have, we can get you the telephone, we can get you the information that you request.
I know that there are. I spoke to people who are. So why don't you say yes? The answer is yes, right?
So when that, the answer is yes? Yes, there is yes.
Okay, so how many are there?
Don't know the number, honestly.
Okay.
I'll get it.
And they could be continued in that status, correct?
They will be reviewed.
They will be reviewed, but they could be reviewed and they could continue to stay in the ESH, which I would call ESH restraint status indefinitely. Is that right?
we would look for alternatives after we had 3 reviews to get them to alternate location.
People did tell me that they were told that they would never get out of stage one status yesterday that I spoke to, and that's certainly not contrary to any part of your policy. So I'm just trying to ask you a question. So I'll ask you another question. Vera, in their presentation to you and in their presentation to us, suggested that a different approach, I think they thought it would be a better approach, would be rather than having to prove that you deserve getting out of ESH restraint status or ESH 2 to 3, that people should, after they've served the time before review, unless there's a reason not to, that they be moved forward. And I know the board has considered, some kind of condition like this for you, and I don't know when this comes up. I don't know if it's written out or.
To clarify, I think we've also had the conversation with Vera, as Vera kind of has stated probably to you, as they've stated to us, they did not evaluate ESH level, ESH within our context during the time of their evaluation. They were taking a look at different incentive models that were across the country and noting that there are some places where they do start first with a time limited. There are others that don't. And they're looking at those options right now because we have noted several jurisdictions are in the process of going through this and evaluating the use of programming desks and other kind of incentive models. Some that actually, these jurisdictions already have punitive segregation and solitary confinement for our population, and they add on this. We actually don't have that and are using this for the adults where we already don't have punitive segregation.
And you're open to the discussion with Vera when they come back with some conclusions?
Absolutely. No, we're always.
But they did make recommendations that when you have a phased model, that the phases should be for a definitive time unless something happens that would prevent the person
So
from
yeah,
moving
what
right.
they've discussed to us is that there could be definitive times, but behavior, and not necessarily a singular act, but behavior itself, as we've tried to model basically participation, infraction rate, other kind of violent behavior, those are all things that we would use in our current chair.
That was one of the reasons why I asked the question about how many people move out, because it really speaks to, so if people are behaving themselves, they're engaging in services, is it more likely that people will move to a less restrictive model as opposed to being stuck in level 1 or in entry? Entry, you clear it up, it's 30 days, the assessment happens, they're out of that. But the place where people can get stuck, and the concern for me is level 1. And so it's good to hear that factoring in all of that really is a determination of what's the least most restrictive option to keep the jail safe, keep inmates safe, keep officers safe.
And at level 1, how many hours are they out of the cell?
7 hours.
That's okay. Which, if we look at, what's it?
With that education, they can be up to 10.
Right. And when we look back to punitive seg, that was
23 hours.
in the cell. Correct. Okay. So this model has, which has been implemented, allows for more time out of the cell, even at level 1. Right.
So this provides more hours out and then access to programming.
Right.
But let's be fair, 4 hours out not playing basketball.
Right.
Yeah.
Right. But still programming.
Programming and education.
Yeah. And they're in this unit because they have committed serious infractions, dangerous behavior, evidence dangerous behavior, and are a security risk to the institution, and to the staff, and to other inmates.
Is that true for level 1, or are you using the look back and cumulative behavior over periods of
So the
incarceration?
entry unit is for the immediate act of stabbing, slashing, or serious injury to staff or another inmate. The level 1 is based on persistent history of violence and or SRG leadership and condoning or setting forth acts of violence by others.
The bottom line, there's documented reasons for why these individuals were placed
That is
there
correct.
for the safety and security of the institution.
My understanding, based upon your support, even though it doesn't look good today, is that the majority of people didn't leave ESH because they got programmed out of it. That people left because they got discharged from the facility, but in general, this doesn't just apply to ESH1 because we don't have data on it. I have a question, which is, how are, why is the material which describes the process of ESH1 and the ESH, admission unit and ESH in general, which we're being asked to discuss here in a public meeting. Why is the directive and all the attachments to that directive and the discussion of the questionnaires that the questions that you ask people, why is that not public information? I understand that there are national security issues, which should not be discussed publicly. I do not understand how we can have a public discussion about, and how people can come here, as they do, to engage in a discussion about whether or not the board should approve a particular program, which is what the directive describes, without having an access. I personally find it just very disturbing that the department considers everything confidential so that no one knows what it is that you're actually proposing.
So I just absolutely disagree. We've been very forthright with the board and the public. We have meetings with the public every other week to talk about what we're doing, both in the ESH level 1 with young adults, adolescents. We don't write policy public, so nobody takes the policy and writes it in the public venue. That's the purpose of the board. We've shared that policy with you. We've had discussions about that policy. We'll continue to work with the board and seek your feedback on the policy. But I think we've been very open, and as again, we've invited board members to actually walk through the units with us, to talk to our staff, talk to the inmates, to get more feedback. I don't, again, I've been doing this a lot of years, Bobby. I don't know of another job where we've been more open and more available to talk about anything anyone wants to talk about.
Why is this directive not?
The directive is a draft form. It's a draft form that we've shared with the board. And once we get a final product that we agree on, then I think we should share it with the public. But
So, Chair, I feel as though we're conflating issues here, and I would appreciate us getting back to talking about whether or not we're going to move to vote on the ESH and the leg restraints, because we're getting into process. And what I would be helpful to know, Bobby, is if you're bringing up process and you're bringing up your concerns because it gives you concern about how the ESH is actually being implemented. Is it being implemented according to the terms, or are you going beyond that? Is your concern with ESH itself, or is your concern with the process and the implementation of ESH?
My concern is that the department has, within the ESH process over the years, particularly in terms of this one, developed practices which are not reflected in directives or processes, and now we're faced with a situation months later where we're discussing something which we really, which doesn't reflect, what the board had agreed to when it made a rule saying that it's okay to put people in the ESH and it's not okay to put young adults in the ESH. So the fact that the directives are we're getting them as confidential directives makes it difficult for me.
And so what you're saying in short is that when you consider and move to vote on the ESH, you're not certain based on what has happened over time whether or not what you were voting on is what actually plays out in practice?
Or will play out in practice, because
So,
it's not the policy.
Well, where we are now, though, is we have a variance in front of us, or we have two variances in front of us, and we also have the commitment to move forward soon thereafter with regard to rulemaking that will kind of address this issue in a more comprehensive fashion. So I take Dr. Cohen's point. I think it's a valid point. But I think what we need to do is to vote on the variances, vote them up or down, and then I think we need to move forward with the rulemaking.
And I'd like to add the conditions, because I think the conditions will give the board an opportunity to engage with the department while the variances, if the variance passes, while the variance is in effect. So I'd like to propose some conditions on the 18-year-olds in ESH. During the pendency of this variance, each request for approval of a placement of a young adult in the ESH must be in writing and specify the reasons why a less restrictive housing setting is not a safe option.
Excuse me one second. Are you now reading the variances? I'm sorry, the conditions for the 19 to 21s or for the 18?
For the 18.
We're now on the, procedurally, we're now taking the first variance request, which was the 18, which was the 19 to 21-year-olds.
So, okay, then let me read the conditions for the 19.
Okay, and so we would propose, we would address the conditions on both at the same time. But if you would start with the 19 to 21s, okay.
During the pendency of this variance, each request for approval of a placement of a young adult in the ESH must be in writing and specify the reasons why a less restrictive housing setting is not a safe option. If the placement is to include the use of restraint desk, the request for approval must include why ESH without restraint desk is not a safe option. The chief of department or designee must also specify his reasons for approving or disapproving the request for ESH placement. If the placement is to include the use of restraint desk, the chief or his designee must separately approve or disapprove this use and specify his reasons for approving or disapproving the use of restraint desks. The request for approval and the chief's or designee's approval or disapproval thereof shall be sent within 24 hours to the person who is the subject of the request, New York City Health and Hospitals, and the board. 2, a young adult can only be placed in EHS entry housing area if the person has recently committed and or participated in an actual or attempted slashing or stabbing or engagement in activity that caused serious injury to an officer, another person in custody, or any other person, and the use of a restraint desk is the least restrictive option necessary for the safety of others. 3, a young adult can only be placed in EHS level 1 if the recommendation from the ESH entry unit assessment recommended continued level 1 placement and the use of a restraint desk continues to be the least restrictive option necessary for the safety of others. 4, during the pendency of this variance, the department shall provide to the board with a monthly public report on the implementation of the foregoing conditions, which shall include the following information. For each request for approval of placement of a young adult in EHS, the reason for placement, the level of placement recommended, whether the placement and placement level was approved or disapproved by the chief of department or designee, and the housing category in which the young adult was housed immediately prior to placement, e.g. General Pop, Second Chance, True, Sure, Secure, ESH, or restrictive APU. B, a summary of young adults in EHS. The summary shall include the average daily population of young adults held, overall by EHS level, the average length of stay of young adults held, overall by EHS level, the number of young adults placed by EHS level, the number of young adults released by level, the number of young adults who had a previous placement during the current incarceration in one of the housing units, EHS, True, Second Chance, or Secure by EHS level, the number of young adults who met the criteria for a 30 or 45-day review, the number of young adults who received such review, and the number of such reviews of young adults that resulted in placement in an alternative housing area or in new EHS level 1. The department shall provide the report on the 10th business day of March, April, May, June, and August, and the 5th business day of July. Individual level data used to generate the report shall be shared directly with BOC board staff. The department shall develop comprehensive metrics and a plan for its ongoing data tracking, monitoring, and evaluation of the implementation of EHS for young adults. Within the context of its continuum of restrictive housing options, final metrics and a monitoring and evaluation plan shall be submitted to the board and presented by the department at the May 9th, 2017 public meeting. The metrics and plan developed shall be in line with national best practices and address the department's compliance with minimum standards and the conditions herein. 2 weeks prior to the board's July 11th, 2017 public meeting, the department shall submit an analysis of EHS for young adults that will include but not be limited to compliance with the department's monitoring and evaluation plan presented in May, and its evaluation of EHS for young adults using metrics presented in May. During the pendency of this variance and on at least a monthly basis, the department shall provide the board access to all documentation considered in each ESH placement and review decisions for young adults. This includes, but is not limited to, all records reviewed or created by EHS adjudication, Health and Hospitals Placement Review, the Chief's Review, the EHS Entry Unit Review Committee, and the ESH 45-day periodic review. On a monthly basis, the department shall transmit a list of all ESH placements and review. And finally, the department shall provide the documentation by the 10th business day of March, April, May, July, and 10th, and the 5th business day of June. If I said a mouthful, it's because
Thank you. So, two things. One, I'm going to ask.
Additional conditions.
Yeah, okay. Okay. One, is there any questions on this particular set of conditions? And secondly, and then I'll come to you, Dr. Cohen. And secondly, back to the department, I wonder if you have anything you'd like to comment on as far as these conditions go.
I have a question on the conditions. Stanley, why did you not decide when you presented these conditions not to limit the amount of time before there was an assessment, the amount of hours per day that people would be, give people the opportunity within the ESH1 or the enhanced assessment unit to spend some hours out of restraints and some hours not in restraint tests? Because as far as I can tell, these conditions just create the kind of information the board should have access to anyway, and are not really conditions for the variance.
Yeah, I think these conditions, what I don't think we want to get into now is rulemaking through conditions. I think we've gotten counsel on that. There's a line between the way in which we can put conditions that allow us to monitor and hold the department accountable for the standards without getting into rulemaking. The other thing is, I think in the variance, there's a cap on the 30 days. There's a review of 45 days with a mandatory review after 2 reviews without any movement, the 30 and the 45 days from the chief, that really digs down on why the person is not moving. And so we are going to be going into rulemaking on restrictive housing. So I think that's where we can get into the particulars of the number of hours people are restrained and that sort of thing.
Chief, do you have anything you want to add?
We're fine with conditions.
Okay. Before we come to your condition, I'd like to take a vote on these conditions. Is there a motion? So moved. Is there a second? So, thank you. If we could go board member by board member, starting with Dr. Safier, and just let if you're in favor of these or opposed. What was the question? The question is whether or not the 19-21-year-old conditions, which Stanley Richards just
I'm in favor.
discussed, and then we had a second and a motion. So now we're having a vote. So we'll start with you, Dr. Safier.
In favor.
Favor.
Yes. In favor.
I support.
These are just the conditions.
Just the
It's
conditions.
an amendment to the
Yes,
variance.
yes.
I support. Yeah. Yes.
Yeah, so do I. Okay, so it's unanimous. The conditions all passed. Now we will, Dr. Cohen, if you want to propose another.
I apologize for everybody having to sit here through all this stuff, but it's part of it has to do with the fact that the department never provides us with this information until 2 working days before, and the board does not have any opportunity to discuss them because we just have the weekend and we don't. And it's a terrible way to function. I think it creates bad variances. Usually it doesn't prevent bad rules, although usually we have a little bit more time. There are a series of, the board staff received a request for additional conditions that were from from 2 board members, including myself. They have not been provided to the board members. Today at our meeting. I'm going to now add some that were proposed by Brian that I support. DOC will collect, report, and demonstrate compliance with our key minimum standards and their own directives, RAE ESH. DOC and BOC shall conduct periodic data and case file reviews of people in ESH to ensure step-down practice matches the policy. The department shall use a multidisciplinary team as described in your directive to make placement decisions and conduct periodic assessments to determine level, movement, and program completion. Establish clear criteria for level progression and ways to complete the program. Consider maximum time frames. Assume progression through the levels of ESH. That's the point that I made before, that unless there was a reason to deny someone progress, they would be assumed to have progress. So it would reverse the current thing where you have to prove that you're ready. Allow for flexibility in the time frame. Communicate with incarcerated people and staff. Develop and use orientation materials with goals, expectations, and criteria for movement through the levels. Revamp staff training on the program, goals, level system, and role in this unit. Established a structured reintegration process for people being released into ESH, from ESH into general population.
Are there any questions or comments anybody wants to ask Dr. Cohen about these? No?
Does the department get an opportunity to comment on the conditions, or?
On Dr. Cohen's proposed condition.
I don't know if they did or they didn't. The BOC staff was here.
In all honesty, I'm just hearing it for the first time, so general reaction, not necessarily stating it. Certainly, we remain committed to the board to work with them on the directive and the policy and the process. These all seem to me, at least on first blush, policy and process issues that we should be addressing in conversation about, as opposed to conditions. So I would certainly commit to the board that we're going to work with them on, as we've shared drafts, we'll continue to share drafts, we'll continue to work with you in small groups and so forth, but that's the general statement. Looks like a policy process that we can certainly work with the board on, but not conditions.
Dr. Cohen?
On which ones? One.
Just on generally, and again, I don't have the memory that I should. But I don't remember all of them, but in general, they seem like more process policy that we should evaluate, we should be using multidisciplinaries. Those are things that we're incorporating in our policies now, and we'll continue to work with the board on them, but they don't seem like conditions. They were necessarily.
So are you saying that in terms of the rulemaking that would follow this process, you would be certainly interested and willing to discuss them all and incorporate them in either a rule that you adopt?
Yeah, no, we're happy to talk.
Or incorporate them as you go along.
That's exactly it. I was just going to say that we'd be happy to kind of work with you on just as policy now, as we kind of finalize a directive for ESH conditions.
Mr. Chair, as the old guy on the board, there was many years that we voted variances up and down. We spent a lot of time making believe we're judges to try to address every single issue in these conditions. I think the conditions that were presented by Stanley, in the spirit of what is trying to be achieved here, works.
So, Dr. Cohen, would you be prepared to withdraw your conditions and work with the department going forward, or if
no, I think we should just have a vote on it.
Should have a vote on it. Is there someone who will propose them? Dr. Cohen, I assume you propose.
I propose them.
Is there a second? Yeah, I'll second them just to get the vote.
Okay, thank you.
Yeah. So we'll start at the end again. Stanley, if you can state your approval or disapproval with Dr. Cohen's conditions.
Yeah, this is a tough one, because I think I have confidence in the department's ability to work with us on trying to have a process, and I don't want to get into rulemaking through conditions and through this process. I want to get into rulemaking The conditions really are about having information to assess whether or not the department is using the current directives, the current policies that they are saying, how people are going to get into EHS. So there are some of those conditions. While I support the conditions that Bobby is proposing, I don't support putting those conditions on this process at this moment. So I don't support those conditions being added right now.
Thank you.
I amplify everything that Stanley just said. I also repeat something that I say all the time, how much I admire Dr. Cohen, his leadership, his care for the people on Rikers Island. So I'm voting no with that in mind.
With everything said, I agree. I also vote no.
So my challenge is similar to what Dr. Cohen presented concerning receiving information from the board, within 48 hours of a meeting. Hearing Dr. Cohen's conditions, I appreciate them, but I feel like I'm in a similar place where I haven't had an opportunity to digest them, to thoroughly consider them. And so, I hear the varying concerns and the different concerns of the board. I hear your concerns, and I'm in a quandary, as we often are. So at this point, I elect not to endorse them or support them, but I don't think that they should be off the table.
Thank you. Dr. Brown?
At this point, I do not support them, but I want to go on record to say that I think that there are good suggestions that warrant further discussion between the department and the Board of Corrections.
Thank you. Two comments, two comments I think that Dr. Cohen made, which are quite valid. One, or maybe three. One, the overall content of the conditions. Two, the comment on the process and how cramped in terms of time frame the process has been. And then the third thing, the need for a more public disclosure on some of the background considerations and the documentation that the department is considering. So I think I'm going to vote against the conditions, but I think as we move forward, we ought to, one of the things, and we move forward in the rulemaking process, and we move forward with the deliberative process with the department prior to rulemaking, I think we ought to make sure that we focus on those three issues and try to bring some positive resolution to them sooner rather than later. So I think the condition fails with the understanding that we will move forward substantively with the content of what Dr. Cohen has proposed. Now we need to take a vote on the variance. This is a variance for 19 to 21-year-olds. We will follow that with a vote on the variance for 18-year-olds. Again, we'll start at the end with Stanley Richards. This is voting on the variance itself.
Are we the conditions? What about?
Yeah, with the conditions.
With the conditions.
Yeah, we've approved the conditions.
So I support the variance with the conditions, and I also want to reiterate the conditions that Bobby laid out are opportunities for us to work on finalizing the directive, because many of the elements of what Bobby raised could be in those directives, and I look forward to the department's work on that. Thank you.
And I think also the question of making the directive publicly available is something that should be at the top of our agenda going forward. Mr. Reagan?
Yes.
Mr. Perino?
Yes.
Jones? Austin?
Yes.
Mr. Chair, there's not been discussion of this motion yet, but I'm going to vote, but I'm going to, not going to, if anybody wants to have discussion,
We
then I'm just going to.
We haven't discussed the variance yet, you said?
Yeah, as I understand, we've moved, we're not voting on we're just voting on the, we've already voted against the rule, so now we're.
No, we voted against your proposed condition.
Right, and we voted for the other conditions, so
Correct.
now what are we voting for?
The variance itself.
Okay, so, but we're voting, generally I thought there's a discussion on a motion, the amended motion. But if not, I will just make a statement.
If there's more discussion to be had.
Okay, well, I just want to say that, that I'm going to vote against this. I've urged my colleagues to vote against it. I think everybody has taken this situation very seriously. I don't think it is really possible for us to function when we don't have a timely receipt of this information, when the public is denied access to the underlying directives, and that I urge us in the future not to collaborate in this kind of process. That we have the time. This is very much like rulemaking. This is like the rulemaking that the board decided would not do before, because it's addressing an issue, ESH, which has been transformed dramatically since what the board received a few years ago. We did not approve putting adolescents into a unit where they would be shackled by their feet for all the time that they were not at a cell. And there was a reason that we didn't let adolescents even into the ESH as it was described, because we were worried that it was going to be a forever unit where some people would never get out, as I believe is the majority case. I want to say that the use of restraint tests that the department has referenced does not describe the use of restraint tests in New York City. I participated in the phone calls with the NYU experts. They were describing the use of restraint tests for people. This is in Washington State, which is where they have anecdotal experience. There are no studies. They said there is no data. They are proposing a study which will begin at some time in the future, but doesn't exist right now. And they were talking about the use of restraint tests for people, particularly who had been in long-term punitive administrative confinement, who had spent years in that, and now were being reintegrated after spending large amounts of time. And they were talking about an hour and a half twice a week when they would be in restraint tests. Having people in restraint tests 7 hours a day for potentially forever, when they're not in the cells, is not what the board understood ESH to be when we allowed it as a rule. And so I'm going to vote against it. I'm going to vote against it now. We should have more data. We should have real data. This has been going on for 3 months. We don't have information. The board has not been provided information as to what the benefits of these units are to date. The board has had extraordinary difficulty receiving basic information from the department. We asked for information regarding the placement of people in ESH, and to date, we have not been provided what we require, which is contrary to the city charter, but consistent with the department's approach to board requests for information right now. This is a policy which is going forward without any comment from H&H. Previously, H&H has expressed their serious concerns, medical concerns, and I assume mental health concerns as well, about the use of prolonged restraint tests, ad forever, potentially. But we did not hear from them today. They have not provided the board with any information. I think that before we make a variance like this, which is not a rule, but will have real effects on people's legs and minds, that we should have gotten a comment from them, but they are not part of this discussion. The viewer report on all the kinds on the administrative and punitive segregation units in Rikers Island, which included ESH, showed is the draft confidential thing that we saw described a real problem in units like ESH not being progressive units, but rather being potentially terminal units, and that the way the department approaches it in several areas is very defective and flawed. One is that the training is very problematic, and there is not, that they observed there was not staff consistency in terms of who's working in these units, and therefore whatever policies there are not applied in a reasonable way. Jeff, I'm sorry. You're really not participating at this point in the meeting. We're voting on this thing.
If I may.
Let me just finish my comment. That we should not condemn people to this, that there should be an expectation of progress through these units, that everyone who has any expertise in this area says that this stuff is only important if it gets forward, if it goes forward, but people can remain in ESH for for a long time, and there's not an expectation, and the prisoners don't expect to be moved, and they don't know how to be moved. I don't think we should be expanding this at this point. So I will finish my comments by saying that I did not put forward my conditions, which would have been to limit because they're not going to win, today, which would have been to make the review in 15 days or 7 days. Who needs a unit that lasts this long? Which is as problematic as this one. I've suggested conditions like that, but you can get a response. Again, we don't have time to look at this stuff. But this is not the way to go. We should not give 6 months, for this to go forward. Our rulemaking will take a long time, and in the meantime, I believe there will be harm that will occur to young adults because of this process. I don't think any of my colleagues on the board have any desire to increase harm. They're trying to accommodate the department, but I vote no to create units for young adults that require them to be confined in their cells for at least 17 hours a day, often more, and only allow them to get out of their cells if they agree to be restrained. Thank you.
So, Chair, if I may, let me first begin by saying that I do appreciate many of the points that you've raised, Dr. Cohen, and I say that most sincerely. I also want to say that, every month, every Tuesday, I show up here seeking, like my fellow board members, to move forward and to ensure the safety and the best opportunities for all who are on Rikers Island and in the other jails. It is difficult to come here very often on days like this when we're forced to make decisions that one, we may have limited information on, but more importantly, we appreciate that in making these decisions, that they may present challenges for people that we are seeking to help and support and not to further harm. I'm just going to put it right out there as a Black, proud woman. It bothers me when we sit here and we talk about these people being placed in shackles, and we liken this to slavery. I don't think those are terms we should just toss about. I'm going to tell you that I went out and I had a conversation, because when I first heard about these leg restraints at our last board meeting, I was stunned. I was startled. I was deeply disturbed. As a Black woman, I am not seeking to put my people in shackles or to enslave them. So I went out and I had a conversation, and I tried to understand a little more. And when I grew to understand that safety is a real issue, when I saw the videos, not just this video that we saw earlier today, but another video showing young people seeking to be educated and being subject to slashing, I was alarmed because I saw young people seeking to be educated, seeking to grow their minds and grow their opportunities while incarcerated. But for those restraints, they could have been gravely harmed. And so I am forced, like my fellow board members, to sit here and to make a choice. And sometimes it seems to be a choice where I'm looking to find the least evil of two situations. And so when I look at ESH, I look at it as there being no other option at this particular point. I have not heard anyone on this board or any of the advocates come forward and present an option that tells me that we can move forward and ensure children's and youth safety, ensure young adult safety, ensure the safety of correction officers while educating those who have caused harm while on Rikers or in any other jail. So I have to sit here and I have to make a choice. And so I look to the leg restraints and I look at how restrictive are they. I don't see these young persons being shackled to a point where they cannot move, where they are not free with their arms and their hands, where they are not free to move their feet. Yes, they are restrained from getting up and moving about. But if, in this moment, it is the best way, until we get to rulemaking, that we can ensure that they have an opportunity to be educated while doing no harm then that's where I stand. That's where I am forced to stand. Because I do not want them to sit in their cells and to not be educated. I do not want them to sit back and decide against being educated because of fear of safety. So this is where I am right now. People may say that it is, falling short, or it's falling on the sword. People may say that I'm opting for a greater harm. It is the best that I know right now, because I am concerned about the safety of all and about the betterment. And one can opine. Bring a psychologist up here to tell me, to debate whether or not I should decide against a child or youth having an opportunity to be educated and being restrained in a way that seems the least restrictive. I need a debate on that, but I can't opine otherwise, and I haven't heard that yet. So at this point, I have to vote in favor.
Thank you very much. Dr. Brown?
Thank you, Jennifer, for sharing that. As a psychologist, I certainly am put in a position of dilemma because Jacqueline and, as you said, restraining individuals was out on the surface may look barbaric, torturous, and things like that, but in reality, you've got to look at the setting in which we're working in. And in corrections, we're having to always make decisions about safety and security of other individuals, to include staff, to include other offenders or detainees. And from my visit there, which the staff took their time to go through this presentation that was seen by the public today, and I believe they have been transparent in every way possible. They have shared information with me, and I know other board members as well. I think that I know I am making an informed decision when I vote to support this variance. I really believe that this is right now short of any other alternative. And what I look at around the country, when we look at special housing units, which really are solitary confinement, where inmates are detainees, whatever you want to call them, are housed 23 hours a day with only 1 hour of showers or 1 hour of visits, this is a far better alternative than what is out there. And I do believe we are on the cusp on the nation in terms of corrections and the way and standards in which we operate. And I also will say, 19 to 21-year-olds are not kids. Okay, they are young adults. And some of these individuals have done very grave harm to other human beings. And if my child was incarcerated or was in that situation, I would want them to be protected. That would be the bottom line. I would want them to be protected from other individuals and protected from themselves. If it was my kid in that situation. And that's how I look at corrections all the time. It could be my father, it could be my mother, it could be my brother, it could be my sister. What treatment would I want them to have? And I don't see this as being torturous or barbaric. And when I hear those words, I'm insulted. To think that people would use it and equate us with some barbaric, torturous system in this world. We are not that. We are way above that. And the folks over here, standing to my right, certainly think through everything that they propose. They're not just throwing these things out here at a whim. They really do. Now, the timing of which we receive things, yeah, can they be better? Absolutely. But I truly understand, having walked in your shoes, walked in tears, walked down special housing units where feces and urine and all that stuff was coming at you. I know what it's like. I know what it's like to work in those places. And my thing is about safety. And I want people to feel safe as well as get programs, because I think the only way in which people really benefit from being incarcerated is when they get programs and when they can make a difference. And the gentleman who presented the stats about these individuals who had dropped out from school, I mean, these kids were at risk from the beginning. Some of them had very little chance, and now they're getting a chance. And that's what we're trying to give them, a chance to get out. So with that, I resoundingly support this variance.
Thank you, Dr. Bryant. I support the variance as well. I think for many of the reasons discussed, it's not a perfect solution. Certainly, we have a long ways to go to move it in a better direction, but given the chance, given the options and the alternatives we have, I think this is the right move at this time, so I support it. And the motion carries. Thank you. Where we are now is we have to have a vote on the conditions for the 18-year-olds, and I understand that the conditions are they identical to the conditions
They're identical conditions.
to the that we discussed and heard about earlier, so I don't think we need to discuss them again. Certainly, they don't need to be presented again. So I think if there's a motion for the conditions that Stanley Richards proposed with regard to... Is there a second?
Second.
We'll take a roll call vote again down, starting at the end. Stanley?
Approve.
Yes.
Approve.
Yes.
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 I vote yes as well, so the conditions carry. Now we have to have a vote on the variance number 2, which relates to the 18-year-olds. Is there a motion for that?
Motion to approve.
Is there a second?
Second.
We'll have a roll call again, starting with Stanley down here.
Approve with excitement to work on the directive that we could get this right. And thank you for not saying that what we are proposing today, what you're proposing today is the answer. You have acknowledged at the very beginning that this is not the answer. This is a step in that process. So thank you for that. And I vote yes with excitement to get to work on the directive. Thank you.
Yes.
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 Yes, the vote on the variance is approved. Now that the board has approved the use of ESH for 18 to 21-year-olds until August 14, 2017, if in advance of the July 2017 board meeting, the department continues to believe it needs a variance to continue the housing young adults in EHS, the department may request a single variance for this cohort. The last thing I'll say on this particular item is that I think we now need to make preparations to begin the rulemaking process as we've discussed. So now we have public comment. Is there a list of people who? Can't read this. Ms. I'm having difficulty reading this, but I'll do the best I can. James Amika Tathmay? No. Alex Abel? Or is it a Bell?
So my name is Alex Abel. I work for the Urban Justice Center. I'm a member of the Jails Action Commission as well. I was going to speak mostly in response to the Correctional Health Services report earlier. My job is to go out to all the city jails, mostly on Rikers, to interview people who are receiving mental health services, specifically about their discharge planning and what kind of services they're receiving in that capacity. Thank you. Specifically about discharge planning, but because I am speaking to people who are all receiving mental health services, I hear a lot of feedback regarding what kind of services they're receiving. And I meet with about, approximately 40 people a week over the course of the year. And so it ends up being a good amount of people. Even though it's anecdotal evidence, it's still, I feel like I notice trends and whatnot. And so I was just hearing what CHS was reporting on. I think that it's true. I do hear from my clients that there is some, I want to make 2 points really. Firstly, that I'm concerned about the people who are not being produced for the visits. I forgot what the exact numbers were. It was like 1,400, something like that. And I'm concerned, what I hear a lot from my clients is that people who are in the general population houses who don't have access to mental health staff on a regular basis, if they have some kind of a problem with medication or if they're not receiving services altogether, they don't have any recourse. They have no way to actually access mental health staff, a psychiatrist, a provider to get their services changed. And I think that, that can go on for weeks and months, and people are like desperate to be seen, and they're not being produced. They're putting themselves on sick call. They file grievances, but particularly for people in the GP houses, that can, people decompensate. And I think that is something that, although stuff is getting more clinical, I feel like the services, I feel like they're getting better. I think there's a vulnerable population there that gets, especially for people who, when they get assessed, they don't necessarily get placed. They don't necessarily start receiving mental health services from the very beginning, and they can go a few months into their time on Rikers without actually starting up those services. And particularly for people who, so that was number one. The second thing I want to say was particularly because we're dealing with people who are, all the people who are inside there, the vast majority of them have a history of trauma. And counseling and actual talk therapy is something that addresses trauma, is the best way to address trauma and work through it. And I think that is something I consistently hear, and I've been hearing for the 2.5 years I've been in this job, is that people want more face-to-face interactions, and I think that is something that if that was provided more, if there was some way to have more consistent, regular counseling, that would get towards some of the preventive kind of measures that would end up preventing violence, so we don't end up, in these discussions where we're, working with shackles and punitive segregation or trying to work out how to deal with violence. The way to deal with violence in general is preventative measures, so you don't have people who are, stuck and unable to work through some of their traumatic history, and traumatic history does lead to violence. So I thought I was speaking like 8 on this, and I had not prepared myself. Anyway, so those are the two things I want to talk about: and access. And on the other, just having witnessed this whole discussion that just took place, without getting into the specifics or anything like that, the one thing that it reminded me of is that every day, I look in the newspaper, and there's another executive order, basically on a national level, that is, top down, and this is not exactly an executive order, but there's this trend of subverting democratic processes that are supposed to lead to good results. And I feel like that's what I'm witnessing right here today, is that there's, the process and the policy are not, they're related to each other. And you end up with a different policy if you have a better process where you work with data more and you hear from more stakeholders instead of just, I feel this is rushed through, and I think that the results, and people are going to be affected by it negatively.
Thank you.
Thank you.
Next speaker is Grace Lee.
Test. Good morning. My name is Grace Lee, and I'm a law student at NYU. I'm interning with the Urban Justice Center Mental Health Project, and I'm here to relate the statement of Mr. Edwin Castro, who is detained at AMKC. He wanted to share his experience with the board, and he approved my presenting this statement to you in this public forum. I was born in 1968. I came here to Rikers on July 6, 2016. Since I've been detained here, I've been helping people learn to read and how to do math. I run an informal class of 6 students. I taught them how to find the circumference of a circle. They like it. Before I was detained here, I had a number of careers, including welding, floor covering, and electric. I like change. I have multiple certifications: air conditioning and refrigeration, floor covering, electrical, small injury repair, and transmission repair, and auto body. At one point, I learned how to fix laundry machines and started my own business fixing laundry machines. I am diabetic in a housing unit with other diabetics. There are 50 people on the unit. Half have diabetes, and the other half gets pills for other injuries and sicknesses. I use a finger stick for my diabetes. For every meal, they give us insulin hours after we eat, instead of before. For example, we eat dinner at 5 p.m. but don't get insulin until 9 p.m. After we get shots, we're supposed to get a snack, but we don't. As a result, our blood sugar goes up when we eat and then drops. The timing of when we get the insulin makes it ineffective at keeping our blood sugar stable. When my blood sugar is high, I'm supposed to get an IV, but I don't. The nurses pressure me to sign a refusal form. They say that if I don't sign the form, I won't get insurance coverage. The nurses come with a stack of refusals with everyone's names filled in already. The machine that measures blood sugar goes up to 600 milligrams per deciliter, but sometimes it just says high for me, which means it's higher than 600. It's dangerous because I could go into a coma, which has happened before, 2 years ago. I have neuropathy in my right arm from diabetes, and the medical staff don't give me anything for it. It's gotten worse since I've gotten here because my sugar has been so high. I also have blurry vision. The food is all starch, pasta, rice, but we're not supposed to eat starch. There's no commissary food for diabetics either. The nurses don't act with the professionalism that I would expect. I can't tell if they're double dipping the needles. The needles are supposed to have a case, but they don't. The nurses put the needles directly into their pockets. The interactions with the nurses are also not private. An officer is always there and everyone else is around. We have different nurses every day. Once I had a nurse who almost gave me Lantus, the type of insulin injection that I am allergic to. I recognized the bottle myself and told her about my allergy. She had to go to look at a computer to see that I wasn't supposed to use Lantus. The information wasn't made readily accessible to her. Everyone in the house is supposed to get sick call, but there's usually no sick call for 2 to 3 weeks. They only take 5 people when they call. One man in my housing unit has a broken leg that's black and blue. It's supposed to be raised, but it's not. He's not getting pain medications, and others of us on the unit bring him food. They also don't provide us with socks, t-shirts, and underwear, each of which we're supposed to have 3 pairs of. People whose families don't send them anything go without these articles of clothing. There's construction going on in our housing unit, so there's dust everywhere, which is visible. It makes our eyes burn and makes us sneeze. There are issues with sanitation. It feels like a dirty shelter here. Thank you for listening.
And you said he's in AMKC?
Yes.
Next speaker, Valentina Morales.
Good afternoon. I wanted to bring to the attention of the board, given the conversation that's happened here today. I did this last meeting, but a majority of the board members had already left, as had the Department of Corrections. And that was just to call the board's attention to a report that MHLS published in conjunction with Disability Rights New York on the use of restraints at Bellevue Hospital Center, and also on the use of restraints on the 2 forensic units. And I wanted to report to the board that MHLS and DRNY have met with Bellevue Hospital, who has formulated an action plan to address those issues. I wanted to say that in listening to the conversation today, and as someone who works as an advocate in the field of mental health, I heard 2 very different words thrown around, which I think are being quite confused. I heard safety and I heard behavior modification, or changing behavior. When we advocate in our circles, both the practitioners and the advocates, we tend to acknowledge our limitations in training and our limitations in expertise. With all due respect, the Department of Corrections expertise is just that, correction. It is not behavior modification. They are very different. They derive from very different areas of thought. If you think Foucault and you think Freud, for example, they approach the person in very different perspectives. One is much more informed about data as related to the brain, to how people react in duress, and the other is dedicated to maintaining and managing people who, for some reason, are experiencing right now a deprivation of liberty as ordered by the law. When I was listening to the data that was presented, it was notable to me that there were no behavior specialists. There were no contributions from those who work in mental health. And I heard a lot about creating changes in behavior by using restrictions. There's plenty of evidence, and I'd ask the board really to consider it and to ask questions, and I'd ask the Department of Corrections to consider it, and the advocates as well, because it seems like there's a sincere lack of real collaboration on achieving what everyone seems to want, which is to create a safe environment. You do not restrict individuals into changing their behavior. It doesn't work that way, not in the long run at least. It enhances paranoid ideations, which create situations where people will inevitably act violently. It contributes to trauma, so to the extent that anyone there might have a diagnosis consistent with PTSD, it's only going to exacerbate those symptoms. Furthermore, I think many of you know that Rikers and the Department of Corrections and all those who are trying still have not come to create an adequate assessment tool when someone is brought to the jail for detecting developmental and intellectual disabilities. You don't know how many of these people have intellectual disabilities. The only reason you should really care if your bottom line is safety is because if you have a developmental or an intellectual disability, your brain functions differently. There is not a one-size-fits-all approach, and it certainly isn't punishment into behavioral change. All you need to do is read the literature and use that in conjunction with your own observations to come to a better understanding of how to formulate a plan that's actually going to work for everyone. You heard testimony from the Department of Education that at least 50% of these individuals have individualized education plans. And if you'll just give me one more moment, I think it's a point that really should be heard. If 50% of these people have IEPs, presumably they have current IEPs, meaning they were in school. But you heard other testimony that said 89% of them were not in school, which means that there is a greater likelihood that among those 89%, there are people with intellectual and developmental disabilities. Again, not going to be appropriately addressed by restraining people. I heard a lot of talk about how, well, these shackles aren't as bad as other shackles. That really seems to miss the point, which is whether or not shackling someone to a table is going to affect a change in the way they relate to others in that environment and the way that they relate to themselves. And I think you'll see, if you read the literature, that in fact, it will not. Furthermore, just coming from the context of mental health, restraints are used in the mental health context for no longer than 2 hours at a time without evaluation. Just let me make this one point, because there's no one else here from the mental health community, which I think is scandalous, folks. They're used for 2 hours, and they're assessed every 2 hours because they are used to address very dangerous situations. Assessing the use of restraints every 30 days, how that's going to be effective in any way is mind-boggling to those of us who work in that field. It's something that would never happen. And again, it's not effective. So if everyone's goal here is to create a safe place, then really I think there's greater thought and greater research that needs to be involved. And personally, I think everyone needs to put aside their perceptions of criticism. There are plenty of people that have asked me for the majority of my career how it is I defend certain people. It's a comment I don't respond to because it's not about me. It's not about you. It's about trying to create a plan to make a safe space where people aren't brutalized, these officers feel safe coming to work, and everyone can kind of just get on with the process.
Next speaker is Grace Price.
So, this one, I Thank you, as always, board members, for allowing me to be the back of the bus. Welcome, Mr. Farino. I'm Grace Price, Kelly Grace Price from the Jails Action Coalition. I'm a proud survivor of many horrible things. 9/11, Rikers are right up there at the top of the list. My bailiwick coming to these meetings for the past 3 years, as many of you know, is to speak for the voiceless and the hopeless women, girls, trans men, and boys that are sexually assaulted, harassed, raped, maligned, and victimized. We went through, I'll call it a movement towards implementing a solid PREA rule last year. I have voiced my discontent with that process. I want to note that I'm still waiting for my FOIA request back from the City Law Department that will reveal when the board received approval from the City Law Department to move forward with its PREA request. But what I really want to highlight is that regardless of the fact that a PREA rule was voted in November of 2016, the directive that was published in May of 2016 still supersedes, it's still published. There's no new directive that's been produced that integrates the small steps forward that, I'm sorry, Martha, there were some large steps forward. I don't want to denigrate that rule entirely. There were some good steps forward, but that's not been addressed. That's totally been left behind. Also, the situation in the visitor center with sexual assaults is crescendoing. It's not getting better. There are no posters anywhere for anyone to see how they can report rape or sexual assault, and that needs to be addressed presto. Alan Figman is an attorney in town. I believe that he sent a representative to speak at the July hearing. He represents over 50 people that have been sexually assaulted in the visitor center on Rikers Island and in other city jails. He is still getting calls every week. So these problems, of course, are not going away. We'll make much ado about them in the coming meetings and hearings. But I just want to remind you that I'm going to still be here trying to clean up and move forward to make sure that the voiceless and the hopeless have a solid safety plan for themselves. Thanks a lot. I appreciate it.
Thank you. So I think that wraps up the agenda. If there's no further items to deal with, I have a motion to adjourn.
So moved.
Second?
Second.
Thank you. We're adjourned.
Yeah.
It's the real